now. We have a peripheral to do. Maybe we might do that this evening. Those that can stay late, we normally stay late in Cardiocare. We do our cases into 2, 3, 4 a.m. If we have 8 cases, we do all the 8 cases till one of us drops on the ground, then we can stop. Somebody came, one cardiologist came here to attack with us. He said we wanted to kill him. Because he ran away, he didn't come back again. He came around 8 a.m. We walked till 5 a.m. the next day. He said, lie, he's never coming back here. So, but that's how we roll. So I will just be talking, and this is a discussion. I was talking about indication for devices, and Dr. Johnson is here. Dr. Nazir is here. We can answer questions. The Medtronic guys are here. Any question I can answer, I'll turn to them. That's the good thing about discussion. Yeah, I did not say it's lecture. I said discussion. So, but I think you will. I hope the correct lecture now is devices, Abi. So you pardon me a little bit. Well, I did not do it on the plane. I did it at 2 a.m. last night to try and prepare these slides so that we can be ready for today. But we had a case last night. It's been terrible. All right, great. So we'll start straight away. Indications for cardiac devices. I think this is one of the very key things that everyone should learn. And like I said, once Dr. Edafe is ready, they are moving the patient into the theater. Once they finish cleaning and draping. Now, one of the key things in our environment is learning how to clean and drape and keeping it, because if anything goes wrong in terms of infection of that device, you know how much the patient and his whole community donated to come together to pay for it. Some people sold their houses, their land. So if the thing gets infected, I don't know what you tell them. So infection control is optimum. When we talk about safety in the cath lab, we'll talk about some of that. So the process of cleaning is a ritual. Unfortunately, we'll not show that but you know, if you're around, if you come around once in a while, if you're in Abuja anytime, pop in. If we have cases, you can join us. So we take time and clean very well. So once he's done with the cleaning, they've draped the patient. As they want to take the puncture, we'll now try and switch over there. So Pamela, I think maybe you should have talked to Monday or somebody that when they're about to take the puncture, they should let us know, so I'll stop. And then we'll now change over. And then, that, like Dr. Yemi Johnson said, is everybody can do it. Everybody. My first temporary pacemaker, there was trouble. They all brought the patient in, and I said, okay, let's go ahead. Let's do it. So I just put it in. What I'm trying to say, I want to encourage some people that are thinking he must travel. So the patient was bad. The patient was rushed in from, I think, Gombe or somewhere, I don't know, somewhere far north, with a lot of arrhythmias, terrible. So the cath lab tech say, Oga, you can do it. Let's do it. So we went there. Quite simply, actually. The same way you do the femoral vein puncture for dialysis. Simple. And we did it, put it, pass the temporary lead until you get to the right atrium. Now you get to the right atrium, you just connect it and press on. Literally the on button. And boom, voila. And after a while, the next few days after we stabilized, we now came and put the permanent device in. Very, so what I'd like to say is that it's doable. In pacemakers, based on my understanding so far, once you learn how to get the puncture, I think the remaining is all over. Once you get the puncture, you just follow it. So if you've already been doing, I used to cover the nephrology a lot when I was in residency. So if you've already been doing central line, tunneled line, you can put a pacemaker, really. It is really that simple. So you now just need just a little bit. This is where to direct all of that. So if you are in a center that has nephrology, start joining up with them when they are doing central or they are doing tunnel lines. Once you get it, you will be able to, it will not take you up to 1 week or 2 weeks in the cath lab. Okay, so I'll just go on to that. So this is Limi Hospitals. I have to, so that my people will not disown me. Limi Hospitals is 40 years this year, and this Cardiocare is one of the hospitals. Audio is not there. Zoom are not hearing. Uh-oh. You have omitted it. Okay, good. Can they hear now?
Yes, sir.
Oh, great. So I hope I did not say anything good. That's why it's good to be here physically. People here physically can hear. So 3 hospitals, and we're 40 this year. And Cardiocare is one of the hospitals. It was the first flagship hospital of the Clinic Hospital Group. And the idea is to try and reverse medical tourism. And Hippocrates, more than 2,000 years ago, says, those who suffer from frequent and strong faints without any manifest cause die suddenly. So this, we believe, was one of the first ideas or that Hippocrates was trying to put together about arrhythmias, sudden cardiac death. And so we know that this thing has been around for quite a while. In our own parlance, we had different kind of juju, witchcraft. The person was just standing, then he fought with his neighbor, then he just collapsed. All those kind of things. We believe that those are all early signs of arrhythmias. Majority of patients are a little bit above, are rated on the old side, especially from the foreign studies. In our environment, I think we still have collecting data, but in our environment, there's a lot to look at. There's a lot to be concerned about. The reason is, if you have a life expectancy of 57, I think it's 57 now, so it means that Medtronic, they are saying that why don't we have enough pacemakers? This is why our life expectancy is low. So before we get to need pacemaker, things have happened, malaria and the like. So, but as people are getting older, cardiologists are increasing. When I came to Abuja, I think there were 4 or 5 cardiologists that I knew of. In fact, I started doing pediatric cardiology. I started doing pediatric echo because they brought one small baby to me, and there was nowhere to refer the person to. So I said, at least I know echo. Let us start looking. So I put the thing there, I opened my book. I already have the consultant, you can't collect it from me again. So I put it in there, I opened my book, and then we started doing pediatric echo till pediatric cardiologists started coming in, because the only person at that time had retired from National Hospital, and there was maybe 4 cardiologists, but now there are quite a number in Abuja. And so you can see as that increases, the care of heart failure, the care of this or that disease will come up, and the need for pacemakers, CRTs will increase. So we'll talk about pacemaker therapy. Of course, we remember that the first artificial pacemaker was in 1932, and thereafter we talked about 1958, when the first pacemaker was said to have been done. And it is said that the person that they put the pacemaker in outlived the surgeon, and the engineer. So, but the most common etiology is typically bradycardia, and we'll just talk about some of it. It's important to know that it's a pulse generator. Can somebody, Pamela, ask Elvis if you can bring one of the old pacemakers that will remove from a patient. I think there's one there. So I can just pass it around so that you can feel it and see what it is. So I saw it too as the first time, maybe like 5 years post-fellowship. That was the first time I held a pacemaker. So just hold your own now so that you too can, when you're telling your residents, no, this thing long ago. Okay, but I don't know about you. Some of you have gone abroad. Nigeria will be. Okay, so this is how it looks like. You have the circuitry and the battery. You have the lead system, and all of them typically last between 4 to 10 years. If you calibrate it well, it will last a little bit longer. Okay, and there is a terminology that is used in terms of coding system. More commonly, the first 3 letters are used. So somehow you need to cram this or know this. Well, if you use it long enough, you will get. So like I said, it's like learning a new language. So the first letter tells us where the pacing occurs. So you will see 3 letters, either A, V, or D. If it's A, it means that it is pacing the atrium. If it is V, it means pacing the ventricle. And if it is D, it is pacing both. And if it's O, none. Now the second letter is where it's sensed. Power. Is where it's sensed. And then sensing means it's trying to pick up the signals from the heart. It's quite simply. Sense, like the word say. And then the third letter is the way the device responds to events. So when he senses something, how does he respond? Does it inhibit the impulses coming from the pacemaker? Does it trigger more impulses or not? I'm explaining it as simply as I want, because the way they have been teaching me since I didn't understand it too. So I'm trying my best to bring it, as low as possible. Yes, the way people used to talk, you will just be talking. Then they'll say they want to do training, they'll bring on a Igbo person. The person will speak, you will not hear anything. So I'm trying to bring it down as low as possible, based on how I understand it. And I'm proud to say I learned ECG on Wikipedia. That is where I learned ECG. That's why if I teach ECG today too, it's really relatively simple. Okay? And the fourth one now is if rate response is active. That is R. So typically you have R or none. So whether there's rate modulation or whether there is no. And then the fifth one is if there's multi-center pacing is employed. Okay, so typically, most times you will see the first one, you will see DDR, you will see DOO, you will see things like that. So once you see that, if anytime you see it, try and stop till you get used to it. Try and stop and think, okay, first letter, pacing, second letter, sensing, third letter, how is the device responding? Fourth letter, what's fourth letter? Rate response. Did I cover it in time? Not enough. Not fast enough. You need to put this in your head. So if you are writing, you need to write it. The act of writing will help you remember a little bit more. So you have the single chamber modes, VOO, VVI, and then you have the dual chamber modes. Okay. Yes.
Sorry, you need to adjust for the Zoom people. We're only seeing the home page.
Okay. Are they seeing it now? So they are seeing this now?
Yes, sir.
Okay, thank you. So what is VOO? Who remembers now? What is VOO? Let me cover it. Eh? You say what? You can still see it on me. So what is VOO? Can we try? So the first letter is what? Is where it's pacing, Abi. The second letter is where it is sensing. And then the third letter is what? The response. Okay, fine. So essentially, what we end up is that if it is only pacing, in this case, VOO means that it's only pacing, right? So it's just pacing. It's not caring what is happening in the heart as it's happening. Okay, that is... yeah, this one is clean. Don't worry, it's clean. You can wash your hand later. It's clean. This is clean. We have been running around with it for... Yeah, so I think you can... Just pass it around. You can just hold it, look at it. You can snap it, take a selfie with it. Yeah. So pass it around, feel it. So that when a patient asks you, how is it going to be? Is it as big as a phone? Is it as big as a mouse? You know what to explain or what to expect to the patient. So just, this is one we removed from somebody after 10 years, I think. No. We removed, this one is actually still working. It's one of the devices from another company for which we had no ability to interrogate. So unfortunately, we have to remove it and change to the device that we can interrogate right here. Okay, so when patients are going abroad too, we typically have to advise them, don't go and put a device that nobody has the programmers in this country. So we now have, so that's VOO. So in this example now, pacemaker is set to pace at 60 beats per minute. And it's just going to do that, irrespective of the intrinsic heart rhythm. What is VVI? Let me move it away. VVI, think about it. Just take a few minutes. Pacing on the ventricle. Sensing the ventricle. Inhibits. Thank you. You see? Say again. No, the response to the events. Is it inhibiting? Is it triggering? Okay. So in this case, actually, if I'm getting it wrong, correct me. I don't say now discussion. Remember, I will say it's a discussion. Please, if you have a question, just trigger, and I'm happy I have people in front that can assist me. So please ask questions. This thing, it took me long to understand it. So that is why. So if anything, if you see me explain something over and over again, it's the one that I suffered to understand. I know the DDR. I say, the DDD. So, and then when you try and cram that thing, it just does not stay. It just does not stay. So it's good to practice it. So in this case now, VVI means it's pacing in the ventricle, it is sensing in the ventricle, and then it's capable of inhibiting the pacemaker rhythm. So what time the pacemaker senses an intrinsic rhythm, so when it senses an intrinsic rhythm, it inhibits itself and allows the intrinsic heart rhythm to come up. Do you understand? And then when it doesn't sense, it picks up, especially when you set the lower limit. So you set the lower limit so that if it doesn't pick a heartbeat within a certain period, give your own, right? And if it picks before then, it will also inhibit. So that is the I that is there, inhibiting. Okay, so it can now inhibit and allow it to happen. If you have any extra, please just add for me. Mr. Julius is doing the CRT downstairs. So I'll just move a little bit faster. Okay, what is VDD? VDD. Yes? What's that? Okay. Okay. We have a picture on the system. Get a picture on the system so that we can show. Let them scan it so that we can just put it on the network. So I will show you the ECG of the patient we're about to do. So that when we stop, you will see. But the patient has a left bundle branch block, NYHA class 3, heart failure, and CRTs really make a lot of difference. As part of my MBA in healthcare management, one of the stuff that we did was checking the health economic effect of a CRTD. Okay, and it's quite significant. Quality adjusted life years of 3.5 years extra, but non-quality adjusted life years of almost 6 years extra. That is significant. Okay, so unfortunately, patients come very, very late, and we might put them on 1 year. Or some of the patients we had, they have a CRT, and then they now get one rapid. Any problem?
Yes, sir. The video recording can show
Video. The sharing. I don't know what is on now. What was I saying? So the patient now went back to, I think he came from my state, Benue. Later they called that he had diarrhea and something and one fever and looking for hospital, one thing, and died from diarrhea. Can you imagine after putting CRT, then have a massive diarrhea looking for ORS and then die from, with the CRT. So unfortunately, some things like that happen. Patient may also have HIV or something, get one infection else. A lot of the cases that we've done, some of them died from cardiac-related events, of course, but the other ones, we are trying to track them and see how we can put together a registry. But others that die from just random, something else. So it's also important to remember that the health system around where you are putting these devices is also important. So they called, the officer was here, they called him in the middle of the night. This person is not breathing well. I think it was in Jalingo or somewhere. But what should they do? There's nothing you can do. Go to the hospital, they are running, so they have to go to the federal, I think FMC Jalingo, and so all those health systems are around. So beyond just doing the interventional in the major cities, the support system also around in the other cities is quite important. So I said, what is VDD? VDD. Yes. Base. Correct. Correct.
Then the last D, both in between and
See, is that not very simple? See? For pediatrics, I think in most cases in pediatrics, we like to do epicardial pacing, especially when there's congenital heart disease, and there's a lot of reasons around that. But it's still the same modalities. I don't know how many pediatric cases have been implanted in Nigeria. Are there much? I don't think they are. number, doing epicardial pacing, Dr. Adamu and Nasarawa. He's coming in on Saturday, so we'll do a pacemaker together with him. So we're reserving the pacemaker, so when he comes, we'll do it together. Okay, so in that case, so in this VDD mode, you know, let me just move. I need to move fast. Sorry, I need to focus on the indications. We don't have time. So the indication for permanent pacing most times is based on the severity of the bradycardia rather than the etiology. So that's what I want us to think about. Sometimes we get so caught up as internal physicians moving stuff about why, what, where. And a lot of the etiology, sarcoidosis, amyloidosis can be very difficult to find or whatsoever reasons. So typically symptomatic sinus bradycardia is typically a reason to pace, and irrespective of the etiology. Now, even if the etiology is due to medications, so if you have a medication you are giving the person that the person absolutely needs, if the person now has symptomatic, it may be an indication to continue medication and pace the person at the same time. Do you understand what we're trying to say? So it's not that, oh, now we have to stop the medication that the patient needs because causing bradycardia. If the patient has to be on that drug, you can continue the drug and then start. So most times, the indication is coming from sinus node dysfunction, SND, or an AV block. Most times. The other things, but I'll just focus on these ones. And in terms of indications for sinus node dysfunction, 3 things will be considered primarily. So if you look through the books, you will see so many class 1, class 2, class 3. I don't know whether you've seen it like that. And eventually you are not so sure what exactly you are doing. That was one of the things I hated first about cardiology. Just tell me what is the correct way. Don't confuse with A, B, 2, and all of that. Okay. Don't confuse with A, B, 2. It can be very confusing. So I'm going to just break it down. Some are more class 1, class 2. I'll highlight them, and then as we go ahead. So this is just for us. You must be careful to separate it from physiologic bradycardia that happens in athletes and the like. And most times, in those cases, you could still get as low as 40, 41. But in that case now, you know, it's a physiologic case, and you may need to watch it. And those people typically are not symptomatic. Now, what you typically will do next is that you may consider doing exercise testing. So exercise testing will try and test for chronotropic incompetence. So this is why exercise testing can be very useful in determining the indication for pacemaker or not. Okay? So how will you not determine the indication of a pacemaker if you don't have a stress test in your center? I don't know. But we need to find ways to get it. So if you're around, we do 3, 4 stress tests every day. So maybe if you have one stress test and you are interested, just tell Dr. Alekon, he can just take you down while we are doing the stress test. Get familiarized with it so that you can now go back, and we hope that we create advocates that will put pressure on your local institutions to get these things ready. Before we get cath lab, let's get all the investigative modalities that are getting to the cath lab. Otherwise, you get the cath lab and to sit down there unutilized. Okay, so you do the chronotropic, check for the chronotropic incompetence. In such cases now, you need to do exercise testing. And the third one now is whether there is sinus arrest, and how often and how long do we have the sinus arrest happening for. So what do you need to do that? What do you need to be able to do that? Holters. Holters are in my opinion, relatively cheap. I think for 500, 800,000, maybe 1 million, you can get a Holter machine. And for most hospitals, they want to buy a CT scan of 500 million. Meanwhile, some of these relatively small things. So I want us to try and get these things in. So you see that you need the ECG, you need the stress, and you need the Holter to be able to put together. So patient coming with bradycardia, you need to put this together and take a decision in that regard. So if you have documented symptomatic bradycardia, so when the patient now goes with their Holter, what you want to do is to make sure that they have a diary. Okay? I think it's okay. What you want to do is to make sure they have a diary so that they can indicate the times they had symptoms. It's quite important. Or in most Holter machines, I don't know, well, let me just use this. It's typically about this size. In most Holter machines, there's a small button on the front. You just teach your patients. So what we have done here is to train all our nurses, all our MOs, They can set up the Holter, they can explain to the patient, and most of the MOs can interpret Holter's stress. We don't, consultants hardly go into those areas, so the MO does most of them. So that's how simple it can get. Okay, I remember when we're training, all of us will come together, one stress, we not sit down. But it's now readily available. So get the patient, just press it. So that when you are reading the Holter, you can now mark and see whether the symptoms correspond with the, so that is quite important. Now, we know that there's also the class 2 indication, whereby you are not able to correspond it. There are symptoms, bradycardia-like symptoms, and you are not able to link actual bradycardia symptoms with the bradycardia with the symptoms of the ECG. That is, he had bradycardia around 2 a.m., but his symptoms were around 4 a.m. And between 3 and 5 a.m., there was no significance. Sometimes you still have to put a pacemaker in those, but that's class 2 indication. In those kind of cases, what we do is we co-consult. In this facility, we co-consult. And I advise you, we're all on WhatsApp. We can talk to each other. We talk every day. To grow in this field, we need to collaborate. So, Dr. Olalekan, what do you think? Dr. Olidubia, what do you think? Dr. Officer, what do you think? So we co-consult. Dr. Edafe, what do you think? So by the time we are getting beyond class 1, we typically try and say, as part of a safety measure, and I'll talk about safety, let 2 consultants agree. So, and you can do that in your centers, especially when you are not sure of the indication. Send the ECG back, 2 of you agree, and then you now go ahead. Nobody is a knowledge island on his own. Okay, so whenever you now have symptomatic chronotropic incompetence, I don't remember if we had anyone chronotropic incompetence. I've not seen any. It's just SND. That was in a Caucasian, 40-year-old. Okay, but the person said, Africa, they said, no, don't put anything in me. I will fly abroad. So she left. But we presented it at the last NCS. We presented the case at the last NCS. So heart rate below 40 without direct link, like I talked about, could sometimes also be an indication. So you have some patients, there's no direct link. They are coming with 32, 36. And there was a patient that was referred here. He came with 28 or 26. He came at night, we have finished 3 procedures, we're going to sleep. When we now heard the heart rate, we say, we can't sleep. Oh. This case, we must do it this night. Okay, so patient coming 26, there's no point checking whether there's symptoms, Holter. Please don't put the person on stress. There's a diagnosis center in town that they put the person on stress, that they got referral for stress test. So they started calling around for, please, resuscitation, that kind of thing. So that's not the kind of person to start testing chronotropic incompetence at that time, in my opinion, based on our unique environment. So I know that some of those things are still done abroad, but here I think we should be cautious a little bit. So pacing has not been proven to prolong survival. So it's important to know, in terms of patients with persistent sinus bradycardia, they just have bradycardia even though symptomatic. So it's therefore used mainly to relieve symptoms. So there are studies that back this. Now, however, we must look at the other side. Those symptoms can be dizziness and the like, but there's a significant reduction of stroke and AF, okay, in this patient. So even though it's not linked to survival, there is a link to stroke and AF, which also has its own negative implications. So that is why one of the reasons why you should also consider doing that, both for those with chronotropic incompetence. Now, if you have chronotropic incompetence, especially those with SND, you need to make sure that rate response should be strongly considered. So it's not one of those that you just want to put any pacemaker, and they say they don't have money, okay, let's just put one of the pacemakers first. No, it's when you want to try, and we are working with a UK-based NGO who have been trying to give us some refurbished pacemakers. That is the one that they take back, they sterilize, they recondition the battery. You can go over 13 years so that the price can come down. And there are a lot of studies that have. I hope this is clear. Why am I holding this? I was trying to demonstrate pacemaker. Holter. Now, AV block is another reason for permanent pacing. And in 3rd degree and advanced 2nd degree AV block, you should consider pacing anytime there are symptoms, anytime there are associated arrhythmias. And the patient I was talking about that I did the temporary pacing had a lot of associated arrhythmias. Once we put in the temporary pacing lead, almost all the arrhythmias ended. They will now have time to be able to put in the other device. Okay. So if you have this patients, I've gone off, Abby. Slide has gone off here. So if you have these patients with associated arrhythmias, they have a third degree AV block and they have associated arrhythmias, you need to put in pacemaker, even if they are not symptomatic. So you should really consider them in that case. Now, sometimes you have a third degree AV block, you have arrhythmias. You want to treat the arrhythmia. Now, most of us in cardiology know that most time when you are treating arrhythmia, you're going to further reduce the heart rate. So you're going to be in trouble. How do you treat the arrhythmia in patient with heart failure and the patient has not quite reached indication for pacemaker? So in that case, you may need to put the pacemaker in and then now treat the arrhythmia so that the pacemaker will now serve to give you the minimum heart rate while you treat the arrhythmia and get the patient out of heart failure. Do you understand something? So these are some things that are not quite. So some of those kind of cases where we meet them, heart rate is 40, lot of or 45, lot of ventricular arrhythmias. You cannot give anything because you will now bring the heart rate lower. If you give amiodarone, if you give beta blocker, anything you give, it will take the heart rate down. You put in your pacemaker, then you can now treat effectively, and that is quite very effective. Okay. Now another group of patients are those they are symptom free. So do you now put in patients that are symptom free? They are symptom free. They are patients in sinus rhythm, but they have these documented periods of asystole greater than 3 seconds. They have an escape rhythm less than 40, or any escape rhythm that is below the AV node. These ones also in AV block you should consider strongly putting a pacemaker. A lot of these cases I typically recommend let 2 people agree. Okay. Now in our environment there's not much litigation, but make sure that you kind of get people to agree, 2 physicians to agree that this is what is the best because it's class 2, class B. I think my sharing has stopped. The thing is going off and on. I think it's going off and on. If you can help me log back in. Now there are other reasons, carotid sinus syncope, and carotid sinus syncope. Who can help remember the definition of carotid sinus syncope? Who can help? Ask, talk. Somebody try. Who can help? Carotid sinus syncope. You remember carotid sinus syncope is typically characterized by, a patient has typically after carotid massage or something, they have asystole lasting 3 seconds, okay, plus or minus hypotension. But in these cases, when they are getting to 6 seconds, then you should really consider having a pacemaker in those patients with. But 3 seconds is the standard for definition. But once you start getting up to 6 seconds, you should really, really consider putting in a pacemaker because 6 seconds is a long time and it will easily degenerate, especially if the patient is not near you. So this is another indication. So you can do that. You should be careful trying to induce it in the clinic, please. You should be careful also. Make sure you also do a carotid Doppler before you try any carotid sinus massage so that you don't take a plaque to the brain. Make sure you don't do both at the same time. Make sure you have all the resuscitation equipment around you, a tropine, everything around you. And typically also, can you help me log back in? And typically also, I typically don't like to do it if I don't have another cardiologist around. There's something you may not see. You need another person to see it. Okay? And so if you have 2 people around, what you are not seeing, Dr. Nazir might see the patient, and from his experience, he can see something that you are focusing on the ECG, somebody is focused on something else, and that split second of response can change a lot in terms of, Zoom has logged out completely. In terms of response. Okay, and then tilt-induced vasovagal syncope. I think there's only one center I know of that has a tilt table. I wanted to get one, but the economics did not work out. I'm sure you know what that means. So the economics did not work out, and then just so few cases that you were doing the tilt table testing, so much money to invest in that regard. So some of these places where the economy doesn't work out is where a lot of PPP is needed, a lot of government intervention is needed. So while they are sorting it out, I can go to the next slide while you are. Okay, so Most times, dual chamber, should we use dual chamber, should we use single chamber? What do you think? Anybody can try bail us out. When she use dual chamber, when she use single chamber. Has the pacemaker gone round? Okay, fine. When she would use dual chamber, when she would use single chamber. Anybody try? Anybody try? Try. Don't worry. Once there's a problem with AV node, either now or in the future, once you think that there's any AV desynchrony or that there could be in the future when you might need, biventricular pacing, by chamber pacing or dual pacing, that's from atrial ventricle, then you need to do that. So, but there are some times when you might want to also do only when a single chamber pacing could be done. So, can we go to the next slide? What's happening with this? Please, sorry to the online audience that you're not seeing the slides. We're working on it to sort it out. So you need a dual chamber pacemaker anytime there's an AV block. So if you have a complete AV block, your choice should be dual chamber. Now sometimes patients, when I came to Abuja, there was, who was the person? Dr. Adamu was the only one putting pacemaker this side of the Niger. So it doesn't matter what it is, it was single chamber pacemaker. You put it first, then you ask questions later. And the single chamber pacemakers were also cheaper, so patients could put them easily. So when you tell somebody single chamber, dual chamber, they think about it like 4-valve or 6-valve Honda. It's not like that. This one is 600,000, this one is 1.2 million. I beg, give me the 600,000 naira. But eventually, pacemaker syndromes, all those kind of things will come in later. Now, if the patient is in heart failure and has prolonged QRS, you should consider doing CRTP. Now, CRTP is a lot cheaper than CRTD. So you should consider doing that if they have prolonged QRS. Now, remember the criteria for CRT. We'll talk about the criteria of CRT a little bit. Now, for single chamber atrial pacemaker, those without AV issues, okay, you can consider putting a single chamber in the atrial. So that is, the AV is fine, it is just sinus node dysfunction. So all you are doing is like, you're kind of replacing the sinus node. However, you should be ready that if there's a problem in the future and there's an AV block, you now have to come back again. So those are some challenges of indications in our environment. So in our environment, you have to think of those socio-cultural issues, and you may want to consider putting a dual chamber ab initio because some people may never be able to come back for that second one, risk of reopening a wound, infection, all of that, fibrosis, it can be quite challenging. So those are some things you should consider. Now for single chamber ventricular pacing, typically when you have atrial problems, so the atrium is chaotic, so trying to pace the atrium and the ventricle, what's the point? Atrium is already chaotic, so chronic AF, when no AV may be needed, you can just do your single chamber in the ventricle pacing and just pace the ventricle. Abi? Correct me, no, you're my yoga. All right, fine. Sorry, this slide is a little bit small, but it's saying exactly what I've said. Just a little bit more detailed and based on the, listen, go to the next slide. Sorry, those online, sorry, we're working on it. But if you catch the next flight, you can still meet us in time before we finish today's work. 200,000. Next flight is 100,000. The only that they will shift it. The flight will not come on time. Okay, okay, fine. Just press play. Next. So this is how we put it. Dr. Johnson already shown it. Local anesthetic first. Did it stop? I think you have to stay there. If you go somewhere else to move. Local anesthetic first to the area. Some people decide to make the incision first before getting the vein, and other people get the vein first before making the incision. Both ways are fine. I typically prefer to get the vein first before I make any incision, so that if trouble there, you can just quickly say trouble, that kind of thing. But when you make the incision, you have already entered, that kind of thing. So, and then you pass the lead directly and try and use the stylus. So if we'll have some time, this one needs to wear gloves. But I think I'll just take it around and I will show you one of a lead. Please.
What of the pre-medication and the some basic investigation? Do you do it in the protocol here, particularly pre-medication?
So pre-medication we do. Now the preliminary investigation. So I'm just talking about indications. Now we're going to talk about the pacemaker implantation proper. But in terms of preliminary investigations, we have to. If you come with investigations from your referring center, and it's an investigation that is verifiable easily, why not? So right now we are trying to take data. We are just starting to take data. So if the echo does not contain some parameters, we may have to do it again so that we get all the data. We don't want to reach 10, 20 years and now not have enough data. So we're trying. We've not been doing it for a while, but we are really just starting now to take full comprehensive data. So typically, full cardiovascular workup in terms of uric acid, EUCR, lipids, all of that as baseline part of studies, HIV and the like, ECG, clotting profile. We don't always do clotting profile. Now, sometimes also you have to consider the cost and renal function. In some centers, and you go to some centers abroad, they do venogram as standard part of their. So they put an IV line here, give the 5 cc's or to 10 mils of contrast, followed by normal saline, and then see how, so you can know how the vein causes, and you can directly. And if there is also a persistent left superior vena cava or any abnormalities, you can see. We had one of those cases here. We had suffered, but I am not with any of them, because if their own spoil, they go bring another one and put them immediately. In our case now, we will send again. They will give us another bill. We'll order another pacemaker again for how many million? Who is going to pay for that one? So we give. Those extra 3 doses or 6 doses will not kill anybody. After all, as they go outside, they will buy drug on the road anyways of antibiotics. So we typically give antibiotics here pre and post. And God has helped us. All our devices, we've not had any infection. We've had a case once where there was bleeding around. The patient had a very low platelet count and had HIV. But eventually we were able to manage it, and we did not need to take it out. So we've not had any of those issues. Okay, so I wanted to show you the lead. I will just go around with it. And if you need, you can just touch that. Are you sure? Is this clean? I think there's some. I don't know whether it is clean, sure. But that's you can see this is not it's coming out at the tip.
Yes.
This part is going into the battery.
The battery.
Yes. So I'll just take it around and show. If you look very carefully, you can see a screw there. This is the part that's going to the battery, and this is the screw. The screw goes in like this. So now you can now see, if you look at the tip now, you can see there's a screw. So what we do is when we put this in, we use something to wind it, and the screw comes out and enters the myocardium and bites into the myocardium. I don't know that you can appreciate. Can you see the screw from inside? Can you see this tip? You can see something like a small, immediately after the wire, you can see the screw like that. So let us appreciate it. Then the other part just goes inside here. When it goes inside here, you just screw it. We are panabitas, you know what I mean? It's like mechanic work. It's the same kind of it. You can see the screw very well coming out. So when we put it here, we put a small clip here. When we roll that clip, typically when we're rolling that clip, we are counting 1, 2, 3, 4, so that we don't bring this one and perforate. You can now get tamponade and other things. And depending on the part of the wall you are in, you could really cause some damage. So we will count it and know when it is. Test it. If the voltage is wrong, we can unscrew it back. We know we counted 15 when we are screwing. We must now count 18 when we are unscrewing to now bring this tip out. I think it's you can see it very well. You can see the tip very well. Okay? You can see the tip of the screw very well, and this is how it goes. Okay. Dr. Sandra. So that you can see the screw edge. So when we put a clip here and we turn it, this screw comes and enters the myocardium. So then there's a hole here. So there's a hole here. You can see a very tiny hole. So inside that tiny hole, it has a stylet. That stylet, we can shape it. That allows this thing to shape. It bends up and down till we get to where we want to use. Then we screw, then we pull out the stylets, and then it becomes floppy. So when the heart is beating, it can be moving. Then this other part now we connect into here and screw. I think the upper one is ventricle. Marshall, upper one is ventricle, Abi? Yes. Ventricle over atrium. Atrium over ventricle, sorry. So atrium, ventricle. Typically, whenever we are putting it in, typically when we are putting it in, we typically have support. You cannot be implanting and trying to program at the same time. But if you have absolutely nothing, you can see the small screw like that. And you can see the screw is still inside here. So when you are doing the fluoroscopy, and I know some people use X-rays or C-arm, if you have a cath lab, it's still better, so that you can see it well. Because if you cannot see it, you might continue screwing, thinking it has not entered, it has not come out. But we can see it as soon as it comes out, and then we can stop immediately after that. I hope this is helpful. Yes, are there any questions so far? Are we live now? Huh? Wait, what happened? It just not connecting.
I don't know. If the pacemaker is
Sorry, ask question, please.
It has two parts. The pacemaker that you see, it has two parts. The battery part and the device part. And the battery part, so we need to explain how you come back later and change those to the battery and leave the circulation. So that when they see the component that it is here, then this is how it is separated and how it is changed. Maybe after 10 years, you change the battery after interrogation when you find out it's no longer energetic enough.
So, yes, truly, if you go back in one of the slides, truly, one part of this is battery and one part, but it's like iPhone. You cannot change your battery and continue using the phone. You must change the entire phone. So typically what happens is that the leads, when you open, the leads are there. You remove this one and put a new one. The problem now is that there's special skill for patients that are pacemaker dependent. That time you need to pull out and enter another one. There's some way to do that. Some people do it under temporary, but there are other ways. We did that in one of the trainings, but I think that's beyond the scope.
Less costly this time when you change the
without the leads. Well, it's not. So this is the main money. So that leads, yes, it costs maybe 50,000 or so. So this is the main money.
The next question is about have you started using the MRI friendly?
All of them are MRI friendly now.
That's fantastic.
We don't use any of the
previous old modern devices. Yeah.
We try and find it for people that cannot afford, because after a while somebody will say somebody is doing it somewhere for so amount. Then you are trying to just do something. So you might say, please, if you have any non-MRI friendly, but as a rule now, I typically don't. If you can't afford it, you can't afford it. Then we can look for those ones that are certified refurbished, and then we can use for you, rather than start putting something that one day we have problem. Now the thing about the MRI, something, it's not just that it's MRI that you can just go to MRI. You still have to come, when you want to do an MRI, you still have to come and turn on the features before you do the MRI. Not that the person will just walk into MRI, and no, it's not like that. You need to turn it off. So that means that if you're not in a city that has a programmer, all those logistics are there. I mean, when that person wants to do MRI, they have to come maybe down here to Abuja for us to activate it. Then they do the MRI close by, and then they finish the MRI, we turn it back off. I think one of the reasons is that if you turn on the MRI feature for long, it will drain down the battery faster. Imagine.
It takes you to your first topic, the DOO mode. So the DOO mode is a magnet mode, meaning that we just keep pacing, irrespective of what the intrinsic is bringing. Just keep pacing. So it's a safety mode. So when you turn on DOO, that's the MRI mode. So what it means is that if the patient does not come back to turn it off, you just keep pacing. So imagine patient who is on demand pacing, after some years becomes pacemaker dependent, or could lead to PMT, pacemaker mediated tachycardia. So that's just the disadvantage.
Thank you very much. I have one here. This one is working.
Yes.
Okay. Thank you very much. Any other questions? Please ask. So typically, like I said, 4 to 10 years, but most people own 8 to 10 years. Now, when you are implanting, you have to check the parameters very well. So that your threshold is set well, your capture frequency, all of that are set well. If you don't get those things well, the battery will run down fast. So typically when you implant, after implanting, you interrogate before the patient leaves, patient space on this admission, and then interrogate 6 weeks after. Sometimes when you come and interrogate, one lead has shifted and it has changed all those thresholds. Unfortunately, you might have to revisit implantation again. Otherwise, that battery 2 years will just run down. So you have to perhaps the site that you chose was not the very best, or it has dislodged, and then all of those things will run down the battery much faster. Any other thing on battery?
The other issue is frequent follow-up as you do for cardiac failure patient. It doesn't mean after the pacemaker you should go until he has something. That frequent follow-up and the check-in anytime they interrogate will guard against failure of the battery or over threshold that will drain the battery quickly. In fact, some of the complication, I think when Dr. Iseko came at the main procedure, he would say, like broken lead. You have never encountered that one.
Well,
Sure. Okay. But it's very dangerous, that one. So when they come after interrogation, you find out it's broken, not even displaced. So that one is a severe complication that if care is not taken may need open heart surgery. But in good hands, they can remove and check and they reset it.
So in most cases, we're able to use a snare and pick up foreign bodies. I've done one before. Somebody was passing
The central
line, and I was trying to pull out, the thing came out. Dr. Dafe did that one. Another one I did. Somebody was passing central catheter, and when you're passing catheter, you hold that wire. They always say hold that wire. Somehow, I think the person was in the hall. I don't know whatever happened there. When he finished passing the wire, the catheter, he said, where is the wire? That's how we entered and saw the wire there, long like that, passed through the inferior vena cava all the way down. So you have to come from down, use a snare and pull it up, pull it out. So sometimes we can still do some of this minimally invasive retrieval, even when you have the breakages or something, so that you don't have to do open heart surgery. That would be really catastrophic.
Yeah, thank you. I think with regard to slides 26, 27, or 28, and just one of the indications, if we can elaborate. This one. Why do we need to wait for this indication with documented periods of these three? So why do we need to wait for the patient to be awake, symptom-free, and in sinus rhythm? I really don't.
Okay, so sometimes the patient has employed by the cardiac with this give pacing. Patient has, now some patients, you just saw their heart rate was 45 or 50 in the clinic. They are symptom-free, nothing, no problem at all. They are awake, they are walking around their normal activities. When you now went and did Holter, you now found out on the Holter that even though they are fine, there are times when for 3 seconds the heart stopped, boom, 1, 2, 3, before the heart continued again. So once we find that, typically you will see on the Holter reading, it will be measuring RR interval. So you see RR interval greater than 2000 milliseconds, typically, and it's happening a lot of times. Then you will now see it. Your Holter will typically try and count it for you. But you cannot depend on the Holter. You need to go through the ECG. You cannot depend on just the automatic reading. You need to go through it. So if you see that happening, or at some point in time the escape reading drops or this happens, even though the patient is asymptomatic, if you find this on your Holter, go ahead. So most of these ones are with symptoms. But this one, patient is symptom-free. So you might check all the pulses in this room. Somebody is having 45 now, 48. Don't just go to sleep and say nothing. Go and make sure that this is not there. Because that 3 seconds can go to 6 seconds, can go to anything. So once you find that, then you indicate. And then you can now go to stress. So that's what they mean by this indication. Okay? I think we've answered a lot of questions. You've seen the devices. For those online, I think you can Google the device. You can't hold this. There's no technology to hold something from here. All right, so where did we stop now? Okay, so the ICD. ICD most times, treatment of choice for primary and secondary prevention of sudden cardiac death from VT or VF, most times. Think of ICD like a pacemaker with extra features. That's how to think of ICD. Just think of it like a pacemaker with extra features. So what you are doing is that you are putting a pacemaker. The pacemaker is a device in. If the patient needs pacing, it will pace. If the patient needs anti-tachycardia pacing, it will give a higher rhythm. So one of the cases we interrogated yesterday, young man, also this young, there's a lot of young people, 38 or 39, clean coronaries. So we put a CRT for him maybe 9 months ago. Maybe we put the CRT, we stopped seeing the guy that was coming regularly. So he now came back again that he's feeling somehow. When we now interrogated, you will see times when he had VT for quite a while, heart rate to 220, and what the device did was to give heart rates, push the heart rate higher, push it to 250, 260 as anti-tachycardia pacing, and then regulate it. So it is better for the patient in the sense that the patient will not have that discomfort of a shock. Okay? It will also, I think it prolongs the battery life a little so that you don't shock as much. So the patient might just feel some tachycardia or some palpitations rather than they are talking in a meeting and bam, or they pass out or stuff like that. So think of it like that. And we know that the footballer Ericsson that has now moved to Man U is carrying it. So Man U is typically surviving on a pacemaker, on an ICD. They can't survive long, obviously. So and then defibrillation when it is needed. Okay, so that if you think the patient may have an AV block or may have an AV block, what you want to do is to put a dual chamber. Just the same way we decided whether to put for pacemaker. It's the same way we decide whether to put for. So if it is just pure primary prevention, that is, there is no evidence of AV block, and you do not suspect that there will be AV block in the future, you may get away with just a single chamber pacemaker. I think I have a picture here. That was the case we did yesterday. I have a picture here. I'll look for it. The case we did yesterday. We did an angio for the man last week. 2 weeks ago. As the man had been having lots of, what do you call it, PVCs, multifocal, heart failure, not referred, say he saw the sign and then just walked in. Bad heart failure. He has been managed in clinics for a long time. Now we saw those multiple diseases, and then we said, okay, let's do angio to be sure that there's no coronary artery disease. Immediately we finished the left side, big coronaries. We pulled out, about to put the right one, while we are talking, pulseless VT. The guy just did like this. Unfortunately for us too, it was one of those hours. Remember I told you that we do marathons. So it was around 3 a.m. By then I have dozed off. Another person was, so by the time they saw, they started banging, then we just rushed and then we shocked. I'll show you a picture of the shock. So the hemodynamic monitor captured the whole thing. When it started, when we shocked, and the time frame, so that we can also test ourselves to see how long. Now, because of the experience of things like this, we had to, and if you are setting up your cath lab, you locate your defibrillator in a place where you can reach for, not that they will start looking for matron's key to go. So we had one case, even the defibrillator was like where the camera is. The time alone to go there, get it, is too long. So we have since, over the past 1.5 years, put the defibrillator just by the bedside. Yeah. Yes, we don't use it so often, but for that one time, you will thank your lucky stars. And you cannot use an AED to start reading, sensing, waiting, analyzing. You don't have that time. So as soon as the thing just started, they just banged the lead glass because I had dozed off. I just grabbed the thing, praying, pam, and the guy was back. And after that, the guy started complaining that there's so much noise in the place that we are disturbing him.
There's a question about all these procedures, including the cath lab, the stress ECG, the Holter, everything you see in those labs, you have to keep the defibrillator aside.
Yeah.
And you have every morning, you put as routine check to see the charges, everything before any procedure. It's like when the common man come to watch the flow, they also come to check the charge. Because sometimes if you don't check, even if it is close to the patient bed, it may have no charge. And then it's like useless one. Yeah.
The NEPA takes like before they change over generator.
So all cardiac lab, they have to get the defibrillator close by.
Okay, so a part of that, and a part of these things, all cardiac labs need to have a standard online UPS. Have an online UPS so that you do not wait for changeover of lights and all of that. They will take lights. I assure you. They will take lights. You know? Now, it so happened there was a time that one generator failed, another generator failed, just the UPS. As in, we had 2-3 generators. We had to send somebody to NEPA to beg NEPA. I take God, beg you. Please. They now gave the light to the wrong person. We went back again, please. You understand? So, all those things are things. We have we have 2 UPS, transformer, 2 generators, all to be able to back up this system. So you can see the amount of effort that you must. So when you see some of those guidelines, you need to domesticate them and also think in our environment, what can I do or what can I, how can I? So a pacemaker is sensing and treating. And I tell patients that it is a guardian angel device. That's a very good way to explain it. One of the reasons I believe that we don't do enough cases is that patients cannot understand it, understand what we are doing. So you say, we're going to put a device, you have MI, or you have post-MI, you have heart failure, you need a device. Then they start thinking, we're going to carry one thing. So the art of counseling is one of the key things in making sure that patients understand it. So some patients will tell you, lie, I'm going to my grave with nothing inside my body. That is not a testimony. To go to your grave, going to your grave before time, no. So you now explain to them that this is a guardian device. If it goes too slow, it starts pacing. It goes too fast, it kills one of these devices. Now, you know, cardioversion, especially when you're having supraventricular tachycardia. Therapy is also indicated in non-sustained VT and inducible VT. Class 3 indications for ICD, I remember that if you do not have a reasonable expectation of survival beyond 1 year, like we're talking about, even if they meet the classification, you should consider not doing it, okay, especially depending on the funding. And it's no indication to a patient with incessant VT and VF. It will just be shocking them back to back. Now, there's another way to go about it. You may want to give medical therapy, start it, and then reduce that VT, VF burden, or you may need to do both at the same time. These are some of them that you need to take a decision per case. So it's not, but generally class 3, incessant VT, VF, the battery will just run down. Every day, the person will become debilitated by the amount of shocks and other things. Masha, do you have any experience around this?
Yes, I do. I'm just looking at the ICD therapy not indicated for patients with VT and VF. So as you said, we've had some patients that had consistent VT and VF. So by the time you implant the ICD, as Dr. Iseko said, the major aim is to program it to a pain-free shock instead of a painful shock. But this type of patient, what you experience is a painful shock. So because the pain-free shock is not able to terminate the episode, so just repeated shock, and then by the end of the day, there's nothing you can do. You just end up turning off the ICD defibrillator futures, meaning it's of no use if you should turn off the futures. Yeah.
So it become useless. So those are some of the kids. I think we had one of the first people that we had here, 35-year-old. So I don't know why they're so young. 35-year-old, incessant. He will be shocked. He will come back. He will be shocked. I mean, there's just no point. And we're doing manual. So somebody will say, should we put this thing? They will remember this guideline. And then we're Yeah? More than 30 seconds, typically. When we are using the EGM, we typically define it a little bit differently based on our calculation. That's when we already have a device inside. What we classify as sustained is a little bit different in that regard. But for the surface Holter, 30 seconds typically. Okay. Syncope of undetermined origin, when you can induce VF. EF less than 35% after 40 days post-MI or non-ischemic dilated cardiomyopathy. Okay? Then non-sustained VT due to prior MI with this EF. So if you have, this is the summary of indications of ICD. Yeah?
And which type of patient did they usually use for ICD?
So we'll talk about this. These are the patients used for ICD.
Yes.
Okay? For CRT, we'll talk about that now.
Okay.
We are going straight to CRT now. Okay, how far now? We're changing the patient, are we?
Yes. So, sorry, sir. We just wanted to give, if you can give us like 3 minutes break while we are changing the patient. Before you continue, then when we are ready, we'll connect back to you.
Okay.
What happened is, we moved the patient. He had, this ECG, I'm sure. Dr. Iseko, no, not this one, sir. The other one. This one was 2017. This ECG, he was still in sinus reading. 2017. But there is one he did.
That was very wide.
Yes, he did 2022. It's with Dr. Laleko, I think so. So he had that one. He had a complete left bundle branch block. Then he is also in AF, and the ejection fraction was around 2024. He has been on optimal medical therapy as much as he can tolerate, but yet the failure still progress. So we enlisted him for the program, and is to have a CRO TD. The D, because the Holter that was done for him, it had a lot of ventricular atopics. So if there is no need to defibrillate, we usually go with a P. There's a patient we are going to give a P in the program. But this one is actually selected for a D because of those high burden of atopy, so that we can take care of the defibrillation in case it goes into that. So when we enter, what we did was that we lie him almost in cardiac position. Although we have downgraded, he came in almost about 2 or 3 days ago into the hospital. We have been on frusemide, and we have downgraded him. He's now NYSH class 2. It's far better. Although the edema is still there, the BP has come up. So after the preparation, what happened was we asked the anesthetist to just give midazolam. But what happened is that the anesthetist that usually work with us is not the one that came today. So propofol was given. So he just went straight. Immediately the propofol was given, we just noticed a fast reading on the monitor, and the patient started gasping. Yeah. So what we did first is to see whether we can see a shockable reading, or we should start a CPR. But he was having intermittent, not sustained VT, which we don't need to shock. So we just tried to see whether we could give. We gave amiodarone, then raise his head up again. So later it reoccur again. That is the fast reading with gasping reoccur again. So we said, well, he's not stable at this moment, so there's no need to take him immediately. So we have to move him out and reconsider him. Maybe at the end of the day, tomorrow, we can take it. So we have to take another case. So you will give us some little time for us to take the next case. So if you have any question, you can ask. We have interesting cases for us to discuss. And
What's the age of this patient?
it's 54. Yeah. What the etiology, we're thinking of a dilated, non-ischemic dilated cardiomyopathy. There is another one, alcoholic dilated cardiomyopathy. That one is the next one we are taking. What actually happened in that one is still have some reserve ROV function, but the left ventricle is markedly dilated, such that on the echo, it pushes the ROV to be a crescentic shape. So he still have some reserve because the ROV has not failed. So he still have some reserve, but the QRS complex is 160, ejection fraction. You know, for that kind of a balloon heart, ejection fraction is really weak, 24-25% on Simpson. So that is the next one we want to take now. And that one, he had a two past history of cardiac arrest. So we are still giving him a D because of he has had a lot of sustained VT, and he has had a VT that was aborted in the hospital. So it's not that we are giving primary, this is secondary prevention. That is what we are giving to this one that we are going to take. So the cases are there. So the aim, as we said, is to ensure that we produce enough interventional cardiology that we can be exporting to every other part of Africa and the world. And I'm sure that is Dr. Iseko's mind. We have been thinking of, we will do it.
The question is that, are these cases not in our hospitals?
Yeah.
All these indications we are talking about, they are there.
There is a case we did, I will show you the case. We did it 2 days ago in the University of Port Harcourt Teaching Hospital. This lady has been formed. You know, the one we did for her, she had MOBI type 2. I will show you some of the ECG. She had MOBI type 2. She had not sustained. Yeah. She had MOBI type 2. She had not sustained VT. She had runs, and she has salvos. And she had had one episode of sudden cardiac arrest in the past. So in that case, when we look at her ejection fraction is still good, but the heart is just all prone to arrhythmia. On a normal ECG, what you see on the normal ECG is by Gemini, one normal beat, one abnormal beat. That is what we feel the ECG throughout. And when we did the 24-hour ECG, the burden of ectopic was 24%. You know, that is extremely very high. So what we did for her, we now gave her a dual chamber ICD. And because as at the time you will see her, you check the pulse, 30-something, 40, or thereabout. When she go into the tachycardia phase, the pulse can rise up to 200. That is how it keep going. So it's tachybrady arrhythmia with a combination of all these rhythms that go on here and there. So the only device that can fit into that is a dual chamber ICD, because you want to pace, you want to defibrillate. And that was what we did. We'll show you the case. Then here, I remember there's a case we did yesterday. Dr. Iseko has shown it. Yeah. Very good. He will show you he was the one that defibrillated the patient when we were doing the angio. It was a non-ischemic cardiomyopathy. Non-ischemic, the heart is so big, but non-ischemic cardiomyopathy, and now the guy has received a dual chamber ICD. He will show you, he will talk more about it.
Any questions? Any other questions? No problem. How long will that take now?
Once this one comes in, let's say the next.
Because I want you to take it as you are taking the incision. I want you to be giving commentary as showing how to get that, so that once you are ready, just let me know. Ready, I'll just put off now and I will continue.
Yeah. Then any question you can be answering them here.
Yes. We always say that cath lab is crisis area. You should be ready for everything. You must be ready. And I believe that the more people you have, so in our cath lab, even the cleaner is extremely important. Sometimes the cleaner that will note the ECG. So I'm telling you, we have to teach everybody, because you don't know who will say, Oga, the way I'm seeing this thing, and you did not take note of something. Everybody's opinion is extremely important. So we don't like to change team. We don't like to change the cleaner. We don't like to change the assistant, the nurse. Everybody has understood each other. If I'm shouting, they know I'm not shouting at you. I'm shouting because I know that's just everybody can understand. And that has made the difference between somebody leaving the cath lab alive or not. Now, when you are starting a new cardiac program, everybody is looking at you to see if anything goes wrong. We said it. This boy, we did, you just say you want to go and do, you know. So you are very, very careful. So you need to keep a full team. So I'm hoping that when you are setting up, I know you are going to be instrumental in setting up your centers. Get a complete team that you trust, that you train. Everybody must know. In fact, our best CPR people are the housekeepers. Oh my God. The team will just be there. They have muscles like this. They will just be going bing, 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 bing. You know, before you do it now, you will just be holding your own back. You know, and they've learned it so well. You do it while you are giving your drugs. Patient comes back, you stent that lesion that you were trying, and then you come out crisis free. I mean, you sleep for 2 days after, but at least, you know, you are happy that you left alive. Okay, fine. So someone was asking about ICD and CRT. So this is from the ESC. This is a slide from the ESC. If you have a patient now with class 1 to 3, and there's high risk of sudden death, like we've talked about, and the QRS is small, typically you can consider ICD in this group. Now, if it is class 4, like we talked about now, I mean, and you're unable to downgrade, you should consider that this person, you know, start writing your will or something. Okay. Now, okay, it's nice actually. So now we have, if it is 120 to 149 without LBBB, okay, this is one of those places where you now have to use some clinical judgment. Okay. For class 1 to 3 without LBBB, you should consider ICD. For class 4, you should consider CRTP. So this is one of the ways to think about it. Now, for those with 120 to 149 with LBB, so you have this one, once greater than 120, you ask yourself, is there LBB or not? Once there's LBB, you are more likely to be thinking of CRT than ICD. So if you have you have LBB in the patient, and you have class 2 to class 4, you should be thinking of CRT. Okay? Now, if you think that there's a risk of sudden death, then make it D instead of just pacing. And then if you have greater than 150, with or without LBB, you should be thinking of CRT also. I don't know that this is a very helpful algorithm. I think Medtronic has a site, I can't remember the name of the site, Screen something. There's a site here that you can go and enter your patient characteristics, and it will help to determine which device I've forgotten the name of the site. Screen link, I've forgotten. When Marshall comes, he'll remind us. So when you go to the site, you can enter 35 years old, QRS time, all of that, and to bring it together and give you a suggestion. So I don't want us to say that patients cannot afford. I want us to give the patients the opportunities. And hopefully when these funds come in form of anything, we can now take it like that. Now this is what the CRT is like. Similar to the pacemaker or dual chamber pacemaker, we have done the RV, we have done the LV. Now we try and cannulate the coronary sinus. So that's what we're going to be seeing when we start transmitting. When you now want to cannulate this coronary sinus, this is typically where the problem is. Okay, skill, because, and then depends on where it is located. Some people are located somehow. So if you have catheters, you have some of those things, you can now better navigate it. Now, because we are a very cost-sensitive population, CRT costs maybe 5 times cheaper than it costs outside the country. CRT costs almost 30 million outside the country in most places, and it costs about 7 million, 6 million here in Nigeria. Okay, but that money is accounted for in my opinion because they have devices. They will tear this open. No. But before we tear it, we will be looking at it very well because this is 500,000 naira you just store open. It did not work. Then you treat it away. You open another 500,000 naira you get. You cannot be charging our people like that. You need to be cautious and all of that. So some of those things, these are the realities of trying to make interventional cardiology practice practical in this country, so that we don't just you start a program and it doesn't continue. It just ends. Okay. Are my slides still showing? Okay, I think you should be showing now. Okay, fine. So So what you will see first typically is we'll go in with the lead. Now, depending, some centers, some people in some centers put a temporary pacemaker for every temporary lead pacemaker for every pacemaker they want to put in. You put the temporary first, so that if they go into any trouble, the temporary one can be pacing while they are doing. In our center, we don't do that. We typically look at the patients and find the ones that are higher risk, and so that we don't unnecessarily increase the cost. Those that we identify as higher risk, when we put it in truly, so that pre-op evaluation in our setting is very critical. And when you want to put it, you should have your temporary pacemaker handy. Easy. Now, the other way you can also do is that defibrillators we have, and most defibrillators also have transcutaneous pacing, so that you can also put front and back and transcutaneously pace where you are trying to get. So typically, most people try and get the RV lead first, so that no matter what happens, you can connect that one and start pacing while you complete the procedure before you connect the device. So do the RV lead, do the RA lead, and then try and get the coronary sinus. Now, sometimes it can take us 6 hours. Sometimes it can take us 1 hour. Sometimes it can take us 30 minutes. You just, somehow, you just enter. We have, it's all over. But sometimes, after that 4 hours, 6 hours, you are still not successful. You will just, after optimal medical therapy for at least 3 months. So remember this. You have a patient that came to you now. As of today, he fits all the criteria for CRT therapy. You should actually wait at least 3 months. Change their drugs. This digoxin, Sloke, fusemite, people just come with that kind of thing. Now change their drugs, put your beta blockers, put your RNIs, put whatever it is you need to do. Give at least 3 months, then reassess. So after 3 months of optimal medical therapy, 2 or more, this is a summary of almost all the indications. The other ones are there, but less than 35%, and one of these. If the LBB, if you have LBB, if you have greater than 150, irrespective of LBB, put a CRT in these patients. If you have 130 to 149, that's 130 to 150, and there's LBB, put. If there is 130 to 150 and there is no LBB, then clinical class 2, so it's one of those ones that you have to think, should I not? And then in those that are 130 to 149 with no LBB, that's class 2B I was talking about, with no LBB. So this is a summary of what it is. This is an algorithm. Heart failure with ejection fraction less than 35%. If the QRS is greater than 130, you ask yourself next, is it sinus rhythm or not? If it is sinus rhythm, if the QRS is greater than 150 with LBB class 1A for CRT, do we get the idea? Now, it is sinus rhythm and it's 130 to 149, and it is not LBB, then this is class 2B. You need to really wait whether or not. So this is one of the cases that we normally think a lot. Now, if it is 130 to 149 and it's LBB, class 1B, go ahead with your CRT. Okay, so more or less, LBB puts. Non-LBB, make sure that the QRS is more than 150. If it is more than 130, think twice about it and reconsider everything in light. In that situation, 2 or more people consult, send ECG, let all of us put our heads together and take a decision together. Now, what sometimes happens is that you might say it has not reached, like Dr. Edafe was trying to talk about this case. You might say it has not reached criteria. You now put an ICD. By next day, the QRS now crosses into that one, but you now bring the patient back, move the ICD and put CRT. Do you get those kind of problems? So sometimes you might think about those socio-economic features that happen here, and you may want to just put the CRT ab initio. But it is a decision that has to be taken, in consonance. Now, if the patient is not sinus rhythm but has atrial fibrillation, okay, and the QRS is greater than that, then it's a class 2 indication. You should consider it. In that case now, the atrial lead, you may have to turn it off, because remember that the atrial fibrillation is just there, so you may have to turn off the atrial lead and only do the biventricular pacing. So irrespective of the rate, biventricular pacing will be happening, and the atrium will just be sensing and giving information, rather than because you cannot be firing that atrium that's already firing at 350. You understand? And that's the case. Now, if a patient needs pacing, normally a patient needs pacing, and you have ejection fraction less than 40, you may want to just do CRT-P. Okay? So ejection fraction less than 40 in a patient that has a wide QRS. So if the patient is wide QRS and has ejection fraction just less than 40, you may have to do CRT-P. And then anybody that reached indication for ICD, remember the patient for indication for ICD, who remembers? Primary and secondary. What were the primary ones? Primary indications for ICD. Yes, Dr. AJ. Huh? Yes. 40 days after. Primary MI, that's primary prevention. The patient has not had any VT yet. Or if he had MI and you can induce a VT on EPS 40 days after, you may also consider putting an ICD. Or you have non-ischemic dilated cardiomyopathy, ejection fraction less than 35%, you may want NYHA 2 to 3, you may want to also put in an ICD. If that patient reads that criteria, and then you cannot see the QRS greater than, you may consider strongly just putting, instead of putting an ICD, put a CRT, even though it is non-LBB. Okay, so this is a good algorithm to use. So one of the first cases I think we put, this is a long case. This is the man I said that later they called us that he had one diarrhea and something, and then just was, I mean, come on. You know, I felt very bad. Because one of the cases we wanted to use and say long-term survival and follow-up after 2 years, you know, then they started trying to bring from somewhere with what looked like an acute looked like an acute infection, really. I don't know whatever happened. So, and then sepsis. So, ejection fraction, ECG QRS was wide, NYK 3 or 4, minimal improvement. We tried to optimize the medical therapy a little bit over the phone, and he came all the way. N-terminal pro-BNP was greater than 6,000, and then we evaluated, we put in the CRT. Within 1 month, we stopped seeing the man. The man became, so part of the thing also is that loss of follow-up, you know, that sometimes happens, and then what to do in follow-up. So this is an image. We're coming to the end. What's happening now? Why is it not playing? Okay, it's playing here. Okay, so we have put in the RV lead. And how can you differentiate the leads or not? Can you see this sleeve on the lead? So if you do a chest X-ray, somebody has a device and you're not sure what kind of device it is. When you do an X-ray, can you see the that has like a sleeve? That is one of the coils that is used for shocking. So once you see this sleeve, then you can be sure that you are likely dealing with an ICD. It's not just a pacemaker, because you can see this. So if it's a pacemaker, it will just be slim like this, no sleeve around it. So this is the RA lead, and you know when you are putting it to the RA appendage, if you have done it very well, it has this wiper-like motion. You can see how it's going like a wiper. So if you are not sure whether you are there, you see that wiper-like motion after you have screwed the lead in. Then you are relatively sure you are there. We put in the RV lead. Now this is the coronary sinus cannula. So when we put it there, we now have to give contrast and get the place and go. One of the patients we try to put in, when we put in lignocaine, the patient has a very massive reaction to lignocaine, local anesthetic. Delusions, not arrhythmia, delusions. He started holding the ground. He started shouting. He said, we had to abort procedure for lignocaine. It was a terrible thing. We had to hold the man down. He was blind too, so he was really agitated. So case cancelled. Unfortunately, we already opened the device. So this is happening. It's one of those realities of Nigeria. Okay, so this is just one of the cases. So we'll see more of this. The same way you put in the pacemaker, you are putting this one. So the added skill for CRT now is to put in that coronary sinus. That is where the main problems come in. Now, if you have the people like Marshall and the other people, the physiologists, and we'll talk about the programming. It's my wish that we have programmers in every geopolitical zone, that if a patient around that area, they can go to this center, at least people can look at it, analyze. Now, you may not be able to analyze completely. If you can just analyze, thank God for WhatsApp technology. You realize what it is, you can show the screen. Somebody else from any part of the world can also direct you into doing what you need to do. Do you get the idea? So once we have the programmer, we can put one in Gombe, put one in Katsina, put one there. Anybody that has a device, they will just come. Once you put it on, we can press this one, press this one. Everybody can. This COVID brought us something really fantastic. We are Zooming now. If not for COVID, those things were not, it was only physical meetings. Okay, so these are some things that we need to know. Are there any questions? Queries? Maybe we'll take a lunch break. Maybe we'll take a short break so that people can stretch their legs, so that we're not flogging them stuff so much. And then if you have scrubs too, you can join them in the cath lab. Maybe after the case, then I will take us on a tour and show us. I'll take us in batches on the tour and show us what does what, how what operates, and all of that. And then, if after the lunch, is lunch available now? Yeah. Okay, so after the lunch too, if we're not still ready, I will take us through. We'll put it on the tables, and we can congregate at different tables, and I'll take us through the coronary angiography procedure, how we do it before we do it. So when we're doing it, you can follow. It's really very simple. I'm telling you, it's simple. Yeah, I'm telling you. So I did not travel. I'm telling you because, the way the thing used to be, they used to do it like one thing, like, hey. I swear, if you can set IV line, you can do it. I'm telling you. I swear. Don't tell anybody I said, oh, I'm online. Sorry. I'm live, Abby. Okay, so, but I'm telling you, that I want us to believe this thing. Look, one day it will be everywhere. It will be everywhere. You remember when IVF came? It was also like that. Now they're doing IVF inside malls. There's a mall here that there's IVF. One shop is doing IVF. I'm telling you, inside the mall. Whether it's right or wrong, I don't know. What I'm trying to say is that it's everywhere now. This thing must get to that point. And I know that it's looking slow, like somebody was saying, but just give us time. And I want everybody to be committed. We can do it. I realize that a lot of this is muscle memory. Once you do one, do two, then your hand just starts getting used to it without even reading first. When you now add reading on top and your background knowledge of cardiology, I believe that we in Nigeria may do much, much better interventions because we have learned the stuff so when I look at an ECG like this, I say, this is LAD. So they say, how do I know? I say, I don't know. We have just learned this thing. This is LAD. We'll go there, we'll see it like that. This is circumflex. You have learned it. You can smell the problem before it happens. So when you now learn something is really, really straightforward. And I'm telling you, I think that if we have 20 cases of angio lined up together, by the 20th one, if you're assisting, you should be able to do a diagnostic angio. It's really that. Maybe you might have some problems here and there, but with supervision, you should be able to do it. And I want us to all believe that. Are there any questions? Are there any questions, queries, issues? So for online audience, we're taking a break. You can join us for food. We will send your food via the chat box. So we'll send your food via the chat box. But those here, we just have a short break, and then we'll take it from there. Yes.
Use that radiation safety officer training anywhere in the world. So appoint somebody locally as a radiation safety officer, and the other person can be sent to know what to do in whatever, and make sure you check your dosimetry regularly. So this last image shows is a new dawn. It's a new dawn of interventional cardiology in Nigeria, and we are going places. So this is just the beginning of greater things to come, and radiation safety is going to be part of it. So just to end, who we are, our services: pediatric cardiology, pediatric nephrology, endocrinology, neonatal intensive care unit, transplant incubator, pediatric neurology, and the guys in our children's hospital. And here's a neonatal echocardiography done with a transport incubator. These are pediatric cardiologist, Dr. Peter Igoche. So, sorry, this is not part of this one, just added, sorry. So, okay, all right. Thank you very much. So hope you enjoyed it. It was short. So I hope you are not tired. We have 1 or 2 more lectures to go, right?
Yes, stop. Come here. Can they give me some new unopened diagnostic catheters. I will not open. Unopened diagnostic catheters. You should bring Amplats JLJR. Thank you very much, Dr. Kingsley. Please help us. There's one CT peripheral angle that they did. That may help us just look at it so that we can determine our peripheral before you go. Case does not look good, so we want to do the peripheral first. We've done the CT. We want to look at it first. They have actually.
The goggles just look like normal goggles. But they have legs.
Is that the goggle?
Yeah. So it only helps to protect from your lens. You understand? No goggles is a 20 milliseconds and you have cataract from radiation. Okay, so it just helps.
I think I should start using this thing now. Well, it's very important, especially if you are considering a long-term career in this. I must not lie, I've not been using the TLD badge very often, I must not lie. But I think I should protect myself and my family and start using more often. Thank you very much for reminding us about safety in this regard. So right now, what I'm going to do, they have finished the CRT actually. They've finished the CRT. I don't know if we have video. They've actually finished the CRT. They were about pulling out the sheets from the coronary sinus. Hopefully, they pull it out and it doesn't come out again. But good, successful. I'm thinking we should do one coronary this evening. For those of you that have already traveled, you're not going to sleep well this night, the bed is not good. There's no light even where you're going. So where are you rushing to? Come, let's go and slug it out in the cath lab. All right, so fine. We'll do one coronary. If you are up to it, hang around. I will show you. I will do it myself, and I will show you how we go about it. But right now, I'm going to show you the process of doing coronary angio. Let them just get some things. We'll show you, and we'll get this person to show it on the screen. I will come. You might bring your camera closer, so that as you are showing me, it will be showing on the screen, I think. So people at the back, or I'll come to the center. Yes. I'll come to the center, then we will now project on the screen. Okay. So, any questions from any of the things we have learned so far today? I really wish we could go around the cath lab so that I could show you what happens where. That's what we're supposed to do now. So, if they finish before then, we normally have a 15-minute turnaround. So, immediately we get the patient out, we'll start cleaning the cath lab for the next patient. One other lecture I wanted us to do is called Safety is Everyone's Responsibility. And that lecture is extremely important. I'll tell you a story on why that lecture is important. One time they brought a patient for that day. We had 9 cases to do. Somehow we had 9 cases to do that day. So as we were doing like bravados, by one case we were about to just start coronary angio. Then we remember that we have not done our safety protocol of a checklist pre-op, which we call a timeout. We stop and we'll do timeouts, check everybody in the lab, check that we have this, check that we have that, cross-check the patient's name, cross-check the patient procedure, cross-check ECG. So, hurry up, don't worry, we don't need that one. I said, let's do it. As soon as we did it, we found out that we had the wrong patient on the table. The patient on the table was for peripheral angio, had some gangrene, and we're about to do coronary angio. We probably would have found a blockage and stented, yes. And the person would have come out still with their leg. That is why safety is important. So if we do not follow those safety protocol, you can end up, the patient that came for ICD, you go and do coronary for, or put CRT. Then find out that, this ECG is normal, or this is not meant, you have already put CRT inside the person, you are your own. So those are quite important things. And then the amount of things that happen, like I gave the story of shocks and all of that. There are so many stories. I told you I've done close to over 400. There are so many stories. And if not for these protocols, honestly, mortality rate would have been very high. And it's not because of the real procedure. Do you understand what I'm saying? If it's the real procedure, you say, okay, cath lab. No. It is the small, small things all around. And if everybody does not do it, safety will be severely compromised. Okay, so let me use this center table. Oh, somebody's eating there. Let me use that center table. Okay. So for those that cannot see, we'll try and project it. And for those online, you can just look on the screen. I need, can you call somebody? Femoral sheath puncture needle. Femoral sheath puncture needle and the like. If they have a used one, great, so that we can use it. If not, the unused ones. They should not open it on our money. But if you go for these foreign trainings, they will just be tearing stents open. Pia, pia, pia. They will just be showing you like that. Come on. Okay. So for those that cannot, oh, you need the light, Abby? Those that cannot see will look there. Okay, so good afternoon, everyone. They are going to bring in some other things, but I'm going to try and show you some of the things for a coronary angio. And if you're around this afternoon, I will do one coronary angio, and then you can be there and you can see all the things I've talked about. Yeah. So these are wearing gloves that these are used. Not necessarily, I don't know how much sterilized or whatever they have been or not. Okay. So that the people that cannot see well can look on the screen. Yeah, you can wear gloves, please. Wear gloves, touch. You're not online. So one of the topics I'm going to talk about tomorrow is arterial access. So when I'm talking about arterial access tomorrow, you will have a better understanding of it as we are doing. These are brand new, unopened, and once we may not open it. So but I want us to just look at it. This, for example, is a JL. It's a JL, Judkins left catheter for coronary. Now, what is happening is that this is 3.5, and what it is measuring actually is this distance from here to here to see how big the aortic root is. Now, the way it is designed, doing a left coronary is very simple because this is designed to just go and enter the coronary, whether you know how to do anything or not. So I'm serious, it's very simple. But you need some liver too. Okay, so so if you look at this, there are two curves. Thank you for asking. So I see questions help better. There are two curves. There's a first curve called the primary curve, and there's a second curve, or the secondary curve. Okay, can we see that? This is the secondary curve. This is the primary curve. So when you engage the see one here. So when we pass this one in, this looks like a 4. From here to here is the one that is 4 centimeters. You understand? So if you are doing your echo and you are seeing that aortic root like 3.5, 3, should give you an idea Okay, typically somebody slim, maybe 3.5, and most normal people 4. Now, when you pass this round into aortic roots, like ascend the aortic arc, and it comes here, this is supposed to rest on the back, on one back of the aorta, and this is supposed to just enter the coronary artery. So it is shaped in such a way that once it passes in, and this is resting on this part, this will give you support here, while this just hooks the coronary artery, and then you do your coronary angiography. It's really that simple. Were you able to get anything?
Yes, sir.
Okay, good. But should I open it? No, I can't open it. I should come like this? Okay, fine. Okay, fine. So what you are seeing here is the full set. Is the full set you are seeing here. There is a puncture needle, typically 18G. There is the full sheet. This is a dilator. This is the sheet that is there. And this is a wire. This is I think it's 018 wire. Huh? Guide wire. I'm looking up the diameter. I think it's 018. 038, sorry. 0.038 guide wire. That's the thickness of the wire. Those thicknesses are important. So with time you will learn more of that. So what we do simply is that I don't want to open it. Can I use a pen? And assume that's it. A pen that I can touch without my glove, Abi.
Okay, you can touch your bro.
Okay, fine. Thank you very much. So let's assume this is the groin. Let's use femoral. Femoral, we do both femoral and radial, but we do more femoral for many reasons. And we'll talk about the choosing of access site tomorrow. Whether to choose femoral, whether to choose radial. Problems you will have in femoral, problems you have in radial. But as a starter, femoral is the simplest one. Okay? So you get the artery, you get the landmarks. I'll teach you all those ones tomorrow. Once you've gotten the artery, you know you are feeling the artery pulsating, boom, boom. You feel the other part is pulsating, you try and put it in between. And then you take assume this is your needle, puncture this something. As soon as you've punctured it, because it's artery, blood should start coming out, and it's bright red. So once you have gotten to that one, the next thing is to carry this guide wire that you're seeing here. Let's assume, no, that's not it. You have one. It's not it, but let's assume this is it. This is not it. This is the 034. So you take the guide wire and then you pass it through the needle into, so by the time you have gotten this thing, you need to stabilize it. Remember, you are just needle directly. Now, who knows the Seldinger technique and modified Seldinger? So in the Seldinger technique, the original Seldinger technique is that you penetrate the artery through and through, front wall, back wall. Then you slowly withdraw. As you withdraw, as you come back into the distance, blood will start coming out. While in the modified Seldinger, you just penetrate the front wall alone, and you're already inside the distance, and the thing starts coming out. So imagine that this thing is inside this blood vessel. If you move small, it won't come out. So you have to find a way and hold it stable like this. Then take the guide wire that you're going to put inside. This one. Same thing. Take the guide wire. Typically, you must make sure that you're not using a very strong one. Now, the back of the guide wire is very strong. It's straight, it's strong. If you put this one, if it enters the side of the wall, it will penetrate the blood vessel and you start bleeding there. And if you don't notice it, you will go and dilate and tear it properly. So you don't use this hard tip of it here. Don't be afraid. You can do it. I believe in you. So we take the back of it. You try and straighten it. Can you see how I straighten it? The guide wire is made in such a way that it is wound on each other. So if you draw on it, it straightens. Can you see that? Try it. Just draw on it. It's like you are drawing back. Try and use one hand. Try and use one hand. No. Use one hand. No. See, take one hand. You are drawing on it. Have I spelled it? No. Can you see? Can you see it was curved before? Now it's not curved again. So once you draw on it, you can see how it straightens out. So with that straightening one is what you now use to enter your, otherwise you cannot enter your blood is gushing out. You are trying to enter like this. You will be there like that. The patient will, your blood will be going pop, 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 before you know it. You are on your own. You get, and most of the patients in heart failure, you cannot now give. Try.
Try to straighten.
Yes, with one hand. Correct. But don't pull it all the way. Just, you are not going to just here. Just at this point, and then straighten it. Then stay like that. Stay. Hold it. Don't move further. When you straighten, you have to press back on that. This thing. You see, you're a natural. Interventional cardiologist. Huh? You say?
You are using one hand to stabilize.
You are stabilizing it too, yes. Yes. This is why you need an assistant. Your assistant is key. And if you have a very good cath lab tech, honestly, those guys know a lot. Your little knowledge, they can assist you all the way. It gets better with time. Then you now put it in. Remember that this blood vessel, this blood vessel is pumping out blood. So you are trying to come and hook it like this and do like this. You go know. But it's a learning curve. You see how. So, but if you are watching and nobody shows you, you will not know what happened. You will just see them go. YouTube will come. One day you say you can do. You will do now. You will not be sweating there to do like this. Okay, I'm telling you the hard truths. So after you have done that, now you now pass the wire is not as long as this. You can see the wire. You now pass your something through. So let's assume this wire is now inside the femoral, right? You can now take out your needle. Remember, it passed through the needle. Take out your needle. Apply some pressure here so you don't lose too much blood. Okay. Some people will take some time and wipe this a little bit so that there are no clots that you push back inside. Now we'll take the. I saw it here now. Dilator. This is not a complete sheet. You give me a complete sheet now. The one that they have used, complete sheet. Complete used femoral sheets. A complete used sheet. So the complete sheet this is a dilator. The dilator is inside the sheet. Okay, it's like a cannula. Good, you are getting it. So the dilator is inside the sheet. So you are going to, the sheet is normally around here, and this thing hooks inside the sheet. You can see the sheet. Can we see the sheet? This white and this one. It has a valve there. This dilator is inside it. So you will now come. Now, if you're using glasses, you know you have to be able to see it well, because this thing must enter this one. So you are doing that. The more you do, the better it becomes. This is not the correct wire, so it's hooking. So it comes out. When it comes out, then you pull out both the dilator. You leave the sheet inside and pull out both the dilator and the wire out of the femoral and leave the sheet. Now, because where is the sheet now? Oh God! Can somebody help me just bring that? Let me check if there's a sheet there.
The whole part?
Yes. Except you can identify the sheet. Sorry, we used to throw these things away. I just told them last week to start keeping a few. There's none here. Okay, I'll just keep it here for now. Pull out the letter and pull out the sheet. Now the sheet has they will bring one now. I don't want to open this one. It will be a complete waste. This is about 100 and something thousand, 90 something thousand. Everything. We don't make toothpick now, so we have to import everything. So there's a small valve there. So once you pull it out, the valve stops blood from coming back. You clean up. You take this side one. The side one looks something like this. Let them bring one now. You take this side one and we withdraw blood. We withdraw typically 3 to 5 mils of blood. You withdraw that blood so that if there's any clot, in the process of doing all of this, for normal diagnosis angio, we don't give heparin. We just heparinize the saline we are using, and we don't give heparin typically, especially if you are doing femoral. If you are doing radial, you give heparin typically 5,000 units or 30 to 50 units per kg. Okay, something like that. So you just flow. So you pull out, you take from this side, withdraw some fluid, withdraw some blood, make sure there is no clot. Once you withdraw, don't push it back. In fact, when you get this one, don't push the first time. Pull out first, so that any clots, any debris, fat, whatever, you bring it out. Put it on your gauze. Then now take fluid and flush it. Now you are ready for your coronary angio. Your sheet is set in place. Look at it, check everything. Now, don't forget, a lot of things can go wrong. Ideally, you bring the fluoroscopy and do another fluoroscopy around there. Ideally, as you are also passing that wire, you do it on that fluoroscope so that it doesn't enter a side branch, enter inferior epigastric artery or somewhere, and you go and try and dilate through that place. You get, so that, so all those kind of problems. But after a while, with time, we just do. We don't have any complications, and you learn how to do it. Are there any questions so far? It's really straightforward, isn't it?
This part, what is it called?
Hemostatic valves introducer. I don't know what it's called. But this is a femoral sheet. So the first one is the sheet, which has a valve. And then you have the puncture needle, 18G puncture needle. So they've packed everything together, and you have the 038 wire, which you will use. So once you just have this whole femoral puncture set with the hemostatic valve, that is all you need to get your access. Yes, please.
What are some of the possible
Complications are many. Complications are many. I will give you a full lecture on it. I have the full one. Complications are many. You can enter this one and come out to the side and go. You can go pass through the vein and enter the artery, and you will not know because the artery is still pumping. You pass your whole thing through. When you finish, you will have had an AV fistula, the artery and the vein, and you will not know. The artery will just be pumping into the vein, so there will be no external bleeding. Blood pressure will just be going down. You get, so you have an AV fistula, so there are problems. You could have a pseudo aneurysm. You could dent the wall, and then it can now form a small aneurysm there. Now, if you puncture too high up, so the goal is to puncture at the femoral head. Why? Because when you want to secure hemostasis, in this part of the wall, we don't use the hemostatic device, the closure device. That increases cost unnecessarily, in my opinion. So, in the US, diagnostic angiography is about $10,000 or something, $20,000. Here, it's about $1,000 now. About $1,000. You can see that difference. So we don't try and do any of those things that may increase costs. Oh, beautiful. Thank you so much. Please wash your hand. Oh, good. So this is the actual one that we use. Okay. You can see that in Nebate. Beautiful, Abby. So you can try this one. And this will have been inside here like this. I hope it can still work. Okay. Okay, good. So this will have been here like this. Can you touch this? Touch it. You can see it's hooked. You cannot quite pull it. There's a hook there. You can see it's locked. Okay. Try and feel it. You can feel it's locked. Okay, thank you. You need to feel it. You cannot see this thing from afar. That's all. It's not easy like that, though. But exactly. Now in the real world too, it's good to practice like this, without pressure. When you are there now, your guy is giving you chance finally to do. Then you now start doing and start struggling like this. Then there's blood everywhere. The blood is just coming. You just confused. So you take your time like this. Understand the steps. Practice it till your hand can move without your mind thinking. You understand?
This one is what you are introducing your body. Yes. And when you remove all this, where this one will remain.
So this one will have been like this inside the femoral. This one.
I will feel it.
Yeah, sure. Yes, let me pass the wire in through. You can see it's not easy like that. Somebody was saying that it's not easy like that. This will have been inside. I hope it's not blocked. I think it's blocked. Let's do it from the other side. It's blocked. Yeah, it's blocked. Likely blood clot or something. Okay, fine. Yeah, you can see. Yeah, you can see. You can see. See, as he just sat down. Okay, somebody was saying something. Yes. Please don't worry. Hold it. Don't worry. We have gloves. Our doctors, we're not afraid of blood. Don't worry. To not splash. You're trying to make it straight, Abby. But you're going to do it with only one hand. You need to be able to do it with one hand like this. Because remember, you're holding needle inside. If you move like this, you can go inside. The other complication that you can have is retroperitoneal bleed. If you went and nicked the back wall, the blood can be leaking posteriorly, slowly into the peritoneum. Now in America, where they regulate everything, if you have 2 or 3 of that in a year, they'll come and shut down your cath lab. Okay, so they are monitoring there are some things that they should not hear. You get, they should not have that kind of complication. Now, remember I said that the level of puncture of the common femoral should be at the level of the femoral head, so that you can have somewhere to press your femoral artery against. If your puncture is too high, you'll be pressing into the abdomen, nowhere to get enough pressure, you are in trouble. So that bleeding can happen, and you can lose 5 liters, you will not know. Do you understand? So problem. Now it can also be too low. Now what other complication can happen? You can go and damage the nerve sheets and whatsoever, all the usual. Now people can bleed. It's the thigh. You can lose 5 liters there without knowing. Now, one of the things is that when you now come and you enter this artery, you missed it. Don't continue doing like this. You know how we do for femoral. Yeah, just come back out. Press. You miss them, no problem. No, nobody die. It is that one you are doing that is causing the trouble. You are now looking for trouble. Bring it out, flush it. Any blood, any fat cells, flush it out. Press, hold. Okay? You are going to miss a few, at least especially as you are starting. Press, hold, allow hemostasis to go 5, 10 minutes, 15 minutes. Then you come back and you go again. Now, this your needle. This is how the needle is. You must make sure that the bevel is facing up, so that when your wire comes in, the wire can go like this. So if you now mistakenly and you were doing like this and your bevel now turns like this, you will sweat. Now if you are unlucky, that wire now passes through the wall, you know that you are in trouble. Vascular surgery. Somebody came for coronary angio, then they start doing surgery on the leg. Or you now lose, God forbid, stories that touch. Okay, so are there any other questions about this?
Yes,
I think it's, please.
Seldinga and modified Seldinga.
Okay. Why the modification?
Yeah.
It's the same thing now. The original guy in the 1700s or whatever, when he was defining it, did this through and through wall and pull back. But now you're in the femoral. You go through and through, you pull back. What if you have some bleeding happening behind there? You're not going to know. So, they still use the modified Seldinga for radial. But it's a small space, anything you can see. You can do that, come back. You can see, do that, those kind of ones there. And some other parts, some other people use it.
Why not just go into the lower and that's all?
Now, so the guy do
They say you could still do it for the radial artery.
Yes, it's about getting it easier. It's about catching it. You know how the arteries, when you catch, it can move or something. So I think it was about, I don't know the why. Huh? You say? So I don't know how they arrived at it or what it, but that's how we met it inside the book. Okay.
Sorry, let me just come in.
Yes,
I
please.
observed where I train in India, they commonly do radial.
Yeah.
So all the angiograms I did personally is through radial, and we use the Seldinga technique. And I find it very easier to get there.
I think it's easier.
No,
the Seldinga is easier actually.
Especially in radial, because you may be in the artery and leave the artery without knowledge. When you're doing Seldinga, as you puncture the back wall, there won't be blood flow.
Then
As
you're
you're
not
coming
back.
in the
Blood will not come back.
Then I easily pass your.
So in the radial, I use it when I'm doing radial.
Within the vessel. Certainly. And the bleeding that you normally have from the posterior wall.
It's not significant. But in the femoral, I think it's significant to you be careful in the femoral. You know how this thing is. You never know. Some people need to just seal normally, and other people you go know. You will be praying, Father. You will be kneeling down somewhere and be praying to God. Okay, so but we do radial and we do femoral, but typically we do more femoral in this center than radial. Why? The extra cost of what they call it, the cocktail. And some of our patients have a very unusual reaction to nitroglycerin. You give small and the blood pressure will just go down and you just start sweating. In fact, a lot of times we think twice. We think again and again. So if we can avoid it, so I'll give you the reasons why we may choose one over the other. But worldwide, femoral is still the most common route. Now, if you have a complex PCI2, you're going to more likely use femoral. You can pass other things. Okay, so. Now, there are also problems. If this thing gets spasm, and it can happen, maybe I'll show you one case. You can't, even that shit, you can't pull it out. If you pull it out, you avulse the artery all the way out. And you on your own, you may use that arm, that hand. So, it's not like it's too much wahala, it's better, it's easier. The patient goes home faster. The patient goes home in 2 hours. They are walking around. They feel more dignified, did not go near their groin. You know? They come out, they sit up, they start gisting with their family. If you do a PCI from there, it's really nice, it's cool. They just did something in their hand, and they went home. It's cooler, really. Bleeding is less. There are so many, advantages. But then, the day that you enter it, you know. But it's really, it is getting ascendancy. As at 2009, maybe only 7% of people were doing, but at 2017, 30-something% of angios are done with radial now. But femoral is still the leading worldwide, including the center. So where did I stop? So now you have passed this one in, you are inside the artery, you pull this one back, and this one is now left, just like a cannula. And this is a valve, so blood is not coming back. We come here, we turn this thing. It will take some time for you to understand this. Don't worry. The first day I did it, I just left it, blood just started rushing back. Then you know which way is closed or open. There's no, I'm sorry, there's no shortcuts. You just learn them. Okay? I don't know whether there's a learning technique, but that's why I learn them with. So you now withdraw. Remember I say you withdraw. After you finish any angio, you must check again. So there are times we have finished the left, we pull out. When we come here to try and withdraw, it's blocked. Clot has blocked it. So if you did not know, and you just went and took your right in, you will carry that clot all the way in on your table there. You will come and have an MI through your angio. So you must remember, and it's easy to forget. That's why you need a team. The day you forget, the person will say, okay, remember to flush. You remember. So everybody must be there. And the more you do it, the less likely you are to forget. So you now take that one, pull out, remember 2 to 5 minutes of blood, give it away. And when it's blocked like that, we pull, we try our best so that we can pull out the clot. When you pull out, you take a longer meal. Sometimes it is not possible. It's blocked. Never push. Never flush. It's not IV line that you flush. Never flush. Otherwise, you are pushing clot fat cells somewhere. So in that kind of case, what we do is that sometimes we take the wire, we pass it back in, pull out the sheet completely, and you will see the clots inside the sheet, and then put a bigger sheet. Because we've already punctured it, we have to put a bigger sheet. Otherwise, you put the same sort of sheet, there will be sheet leakage. So you put a bigger sheet that will cover again, and then you continue your case. Don't worry, they happen. No need to feel anything. So now this sheet is inside. The next thing now is, the best thing for beginners is to start with left. Left is easy. That right, the stories are much. So you take the left now. Now, you can see how this thing is bent. Because it is bent like this, you should not pass through the catheter, through the aorta like this. You could scratch the wall. If you are pulling out too, if you pull it like this, it will scratch the wall. You could dislodge a plaque. You could do a lot of damage. So you pass the wire in first. Remember again, the soft J-tip portion is the one that will go in. So typically, your assistant will have loaded it for you. But if he has not, or he's doing something else, you load it yourself. I'm not sure this is the correct wire for this thing, but the wire is just old. Maybe it's a better wire. Now, you never keep the wire straight. You have to turn the wire Now, as you are bringing out the wire too, you have to learn that skill. Yes, as you are bringing it out, you'll be turning it so that it doesn't start splashing blood. You bring it out, you turn it, you bring it out, you turn it. It's a skill you have to still learn. You practice outside the lab like I'm doing like this. You just take some time. When you come inside, you'll be as if you have been there for a while. So, take it, come straight, come inside, and you go in. Now this has gone in, you go in with the wire. The wire must come out. Before you enter this sheet, when you are entering this sheet, you are entering like this. The wire will not show. You enter wire back. So imagine the wire is inside, the wire is back. You enter just as the sheet is. Just like this. So let's do it together. The wire must be inside, it will be loaded though, just maybe to stop here. Then you now enter the sheet. As soon as you enter the sheet small, then you push the wire forward. So the wire will now lead the way through. Then as you come out, the wire is straight and keeping it straight. Take it to the aortic root. When you do the aortic root, you pull out the wire. As you pull out the wire, most cases, the thing will just sit down for you. Bam. Almost 80% of the cases, the thing is made to just sit down like that. So you can see that the hardest work first is just to get that femoral artery. Once you've gotten it, the remaining, these things are devised by people that have suffered before us, right? So once you get there, this will now come into hook. If you have a smaller one, it will be dangling. You may hook before you pass it to fall out again. So you may have to resize it. So it's better to size it very well so that you manage the cost for the hospital and make sure your cath lab does not shut down. Okay? So if you are doing revolving fund like we used to do in government, I think do revolving fund in government hospitals, Abi. And if you are doing revolving fund now, you come and start using 5 catheters. Before you know it, nothing for anybody. We no get catheter. CMD, please approve. Okay, so you take it, make sure you try and measure, look at the patient, do all of that. Now, sometimes we have gone in, the patient, either the echo was not done well, or we also emergency. The patient maybe has a big aortic root or aortic aneurysm or something. Is this thing working? Are you showing this thing at all? So, patient has a big aortic root, this one will just go and be swinging in there. So you have to now get maybe JL5, JL6, big one that will come and truly anchor and hook there. So you've got in there. For the left, it's very simple. It goes and hooks. Sometimes it doesn't hook. All you need to do, you can hold this part. All you need to do is to turn it. You can see it's like this thing. So let's assume this is this thing. When you turn, it transmits it all the way. So the way they have made this thing, they've made it a little bit high torque. When you turn, the effect is felt all the way up. So as you turn like that, the effect is turning a little bit. So you might have to turn a little bit, pull back a little bit, position a bit, give a small puff of... Who was saying pull back a little? Ado, okay. So it's the right that wahala is there. So you give a small puff. You see you are in the catheter, in the artery. Now, are there problems? Are there complications that can happen with this? It looks simple. You could enter the, let's assume this is the coronary. You could enter the coronary and face like this. You think you are inside. When you now load your dye, it will just take the inside and tear the left main and dissect it along that line. Okay? It did happen. It does not happen. Vessels. Now there are two ways. There's the standard way and there's the Nigerian way. So, are we online? I will not say the other one. Okay, so how will you know? We typically connect this to a manifold. Mr. Nakala, can you call somebody to bring manifold? If you bring a used manifold, though. So, say they count the money. So you put the manifold. The manifold is just think of it like an adapter. Think of it like an adapter. It has 3 drip giving sets kind of supplies. One will connect it to pressure. One will connect it to fluid to give pressure in the fluid. Another one will connect it to the saline. Okay. So what we do is that when you get this one you have gotten in, leave the something, let blood come out. So blood is coming out. If blood is not coming out, you are likely against the wall. So you may need to pull back a little bit and you see the blood coming out. Then this manifold, you open it so that the fluid is coming out. So you know there are 3 stops. So you open so fluid is coming out. We do flow to flow. Don't forget that. Flow to flow. So that you don't go and introduce air into the coronary. You're on your own. Okay? So some of these things you just learn them by doing them, and you don't know the wrong task. This one step, every step is important. So the day that you forget one step, that's when you will know why it is important. Because you will not live there. You will not sleep for the next 3 days. But thank God, we've not had any of those cases by the grace of God. So, so the flow is coming out now on this side, right? Fluid is coming out from this side, blood is coming out of this side. So opportunity for air is not much. Then you take them together and then you close the manifold. Then you can close it. As soon as you close it, you open your hemodynamic. This one is pressure, Abi, and you will see your hemodynamic flow. So this is why every cardiologist must learn hemodynamics. If you are going for part 2 and you meet, I don't know if you see there now, Professor Balogun, he will be drawing. As you are talking, he will be drawing. Explain. You just one kind of sweat here, and then one hit at the back of the head. Okay, so if you don't know it, so you will see the hemodynamic waveform. So it's giving the direct intra-aortic pressure from there. If it's against a wall, there's a particular pattern called damping, and you will see it. That will tell you don't give. You might have to pull back a little bit or readjust, maybe turn a little bit, so it now fits in properly. Okay, and sometimes you are too deep into the vessel too. You may, so some vessels, as soon as the left main started, another branch came out immediately. You now went too deep and blocked here. You block off this one. Bam. You don't finish. Especially if it's a conus branch supplying the SA nodes. When you're on your own, you are so on your own, and you don't notice this in time. You are on your own. So this again, another reason for team. And that person is there, and that person is there, and at least 2-3 of them understand what's happening. Okay, your catheter is too deep. You pull it back, prayer block comes back, everybody relaxes. This is likely a short left main. It's not a typical left main that it starts from here. So everybody, but you have other people that can. So that teamwork, I cannot emphasize it enough. It is what will save you. You can't be a lone champion. You will be alone in the cemetery too. Okay, so now you now follow that pressure. Now sometimes people, not everybody uses the manifold because the coronary angio may be normal. So you just did the angio normal. You now added the extra cost of the manifold, threw it away. And that patient came, he did another one, threw it away. So sometimes not everybody uses the manifold. That's in Nigeria. That's the Nigerian stroke Indian way. Okay, so some places in India, but when you are doing that, you must know what you are doing. It's not when you are starting, you don't go and try down, because if you do it now, you tear. How do you explain yourself? So you should know how to do that, and then at least you save cost. Especially if it's a normal vessel, you just come out, you have saved your cost, you continue, and you can prolong your program. And some of these things, any small change in NAFDAC, SON, customs, it's another person. Anything you are bringing in, all of them must, their own must be inside. So if they do anything like this, you will not see. So even that one you are using, it's not just about price now, it's about availability. So if you waste it unnecessarily, you will have a patient, and you cannot do PCI without that manifold. Because in PCI, you must be monitoring that pressure. If not, as soon as you deploy a stent, chaos can happen and you will not see it in time. Before your cough will come, too late. But if you see it early, you have those things. So that's what you do for that. So we have finished the left. I'll teach you, we'll talk about the views a little bit, and I think Dr. Nazir is taking a lecture about that. Now to come to the right. The right is normally the hardest one when you are starting. Why? Because it doesn't just go and sit easily. See the right one. You can see it's just one curve, like almost one curve. There's a small primary secondary curve here and this curve. So for the right, when we take all the way in, where are those people that were saying pull back? It's now that the pullback comes in. Don't worry, we'll learn all of that tomorrow. And I think if we are able to do the coronary that we have today, and you're around, then we'll just go through it. I don't think to be hard. So for this one now, you still will go the same way. Put the catheter tip in first, then you pass your wire and let the wire lead you all the way to the aortic root. When you are going to the root, pull out your wire. Now you will now start turning this one. You want to turn it, in my view, to face your left. For me, in most cases, if you're looking at it, your left coronary is on your right coronary, because you are facing the patient now. So you want it to face that way. As it turns there, you want to pull back a little bit so that it jumps into the right coronary. So I don't know if you understand. Once you land, it's going to be facing this way. You want to turn. You're going to put your hand, one hand here and one hand. So one hand here, one hand here. You're going to turn, and the torque is transmitting all the way. Once it now turns to the desired position, you hold this hand again so that it doesn't turn back, because you turn back. Hold this hand, then you pull just a bit and it will just enter. That's what they talk about. When you enter inside, it's they enter into you go do, before you know, you don't pull far. But after a while of failing, then you just get the hang of it. You just realize that you now know the correct amount of pull or push or whatsoever to do. Now sometimes it's facing another direction and all of that. So you can now come and use amplats. Some people like to use amplats. See amplats on. See the way it is shaped. It's not an easy one to use. And the risk of rupture and dissection is higher with amplats. So I will not advise anybody just starting to use that. Are there any questions so far?
How do you know when you are using the right? How do you get to the place where you have to do the maneuver?
You can see the heart silhouette like an X-ray. You have pulled your wire down. Okay? You have got to that point, you pull out the wire. So you can see the heart silhouette. And as you're pushing it, you will see it hitting against the aortic valve. If you push too much, it will just drop into the LV. Now, if it drops into the LV, one of the things you notice first is VTAC. You will just see VTAC. Pa, 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 pa. If you don't see it in time, your OYO. So, first of all, you see VTAC, patient will also complain of some pain. Or the next thing you can see, if it doesn't cause VTAC, is that the arterial waveform will change. You know what the hemodynamic structure should be in the left ventricle. Typically, it will be like 100/0. So you see a very up 1/0, up 1/0, you know you're in the left ventricle. The people around you too, you have a good team, you tell your guy you are in the wrong place. So all those things are all important in so you now pull it back, you're now back out. So you know around where. You also have your syringe that you have put here with saline, is with you. So you give a small puff too, you can see around where you are. So when you are searching for it, I like to use the contrast at that time, because you are going to be giving a little bit, so that you don't overload the person with contrast. You just want to have an idea of what you are doing. But the right is a little bit harder to get. Then you do your multiple views, which we'll talk about later. So now we are finished. It's not very simple. No, in practice, in real life, it's actually there's no. I'm telling you.
You have a blood sheet. You can move it to flush, but before that, you can set
the guide wire. It is possible, but if you don't reset the guide wire and you are pulling out, you have to repuncture again. To repuncture again means you're not going to puncture the exact point. You remember, eventually you're going to have puncture sites around the vessel. You are in trouble. So you typically put a wire, pull it out over the wire. Most times you will see the clot inside the something. Sometimes you may flush it and go back, but you may know that there's in.
Can it not also push both?
It's possible. It's not impossible. It's possible. Now for the radial, if you are using radial, the catheter is Tiger catheter most times or Jackie. So in that one, that same catheter you can use for both right and left. Once you finish the left, you pull it back, you turn, do the same maneuvers, and you hook the right, and then you go ahead with it. So it's cool actually, and the person is just putting their hand there you don't feel much, but that is what it is. So now you have finished that one. Now what happens next? There is lesion, Abi. You now have to change. This one is very tiny. It can't carry stents, it can't carry balloon. You now go on to the more expensive guide wires, guide catheters. This is a guide catheter. And oh, good. Thank you. Please wash your hand, though. Wash your hand. So this is the manifold I was talking about. So this part is connected to the catheter like this, and then typically they will take a lot of time to flush this one of any air bubble. First one typically is to pressure, second one is to saline under pressure on a pressure bag, and the third one to contrast, and then this one to your syringe. So this is exactly how it is. So once you do like this, if you turn it this way, if you turn it this way, then it's now close to the rest. It means it's going towards pressure, that you can be reading your pressure. If you open it like this, it means you can push your, like you want to give your contrast. You can push your contrast. So typically, you push it this way first. So it is now, this place is now open in this direction. You withdraw contrast from this place. Then you open it like this, then you push your contrast. And you opacify the vessel, see what it is. When you finish, you close. If you leave it and forget it open, that sometimes happen, when you come back, you know the artery is pumping at high pressure, you will just be seeing. Now sometimes too, you forget this one like this. That fluid will just be loading the coronaries, with IV fluid. So all those things are reasons why you must keep yourself. You must first make sure that your mind is you have done it enough time that some things you cannot make a mistake. It's just like you cannot make a mistake brushing your teeth. You can't mistakenly brush your ear. So you should have done it so many times that it should be natural for your hand to just do some things before you even think why you are doing those things. So you cannot remember all the whys. So you need to get your hand to do some of them. Exactly. So this is what the manifold is all about. Then you now take one. All these are where's the pressure? Right. There's a short line. Okay, anyway, so I was talking about diagnostic. This looks like an extra backup catheter. What that means is that we call it XBU or EBU. What that means is that it gives you extra support. When you are trying to pass a blocked coronary, sometimes when you try and pass that wire, it will push out the catheter. So if you have a good kite catheter, a little bit more expensive as well, it gives you that extra support. So that's why we call them XBU. One brand calls it XBU, another brand calls it EBU. Now sometimes we now have to have, especially in those CTOs, we now have to use what we call a guide extender. That guide extender is a lot of money and it's not available too. So that's why when we have complex PCI, it costs a lot. For that guide extender, it's like we pass another guide catheter through this. It will enter into the coronary vessel and kind of extend the hook so that when you are pushing, there's a longer amount of guide catheter inside the coronary and it's not able to pull out. Do you understand? So you have put it there, then you take your coronary wires. There's no coronary wires here. But the coronary wire is like this, only that it is thinner, much more tiny. And there are different types. I hope we'll have time to talk about the different types of wires, what kind of wire to use when, whatsoever, and the weight of the wire. If you use the wrong wire, you perforate. You go the wrong way. So you now pass the wire through the lesion, and over that wire you pass your balloon, over that wire you pass your stent. I want to show you a balloon. I think there was a balloon here. This device is inflation device. This is what we use to inflate balloon or stents. We don't use a syringe. I used to think it was syringe that it just inflates this. It's not syringe. So it's this one. So we pull back. We get you mix here with mixture of 50-50 saline and contrast. You pull back. You have some saline here. Then when you want, you are now giving your pressure. As you are turning this thing, you are seeing the amount of atmospheres of pressure. Okay, on all the stents and the balloons, there is a rating that says this is the normal pressure and this is the bursting pressure. After this one, you are OYO. So you look at that and then you will be turning it till you get to the pressure that you want to get to, and you're looking at it on the screen. So you look at it, it gets to 8, typically between 8, 12, most ones around 8, 12, 6, 8. You get it to 8, you finish, you press and pull back. It deflates again. You do it again till you inflate your this thing. You understand, right? It's simple, isn't it? It's actually simple. It's just that if the first time we are seeing it, so you see it again, you see it again. Now, if you go to the cath lab and we are doing a coronary angio, and they are doing it and you are seeing it, you should be able to know what step is happening next. What normally happens is that it takes you 3 months to know this is what actually they are doing next after this one. Because you are just standing there, everybody just doing, you will not, even that wire that you are doing, you will not see it. You will be there. So around the 6 months time, that's why people that go to India for 3 months, 6 months, they go, when they come back, they just know cath lab is like this, like this. So if you don't, I mean, that's what happens. Yeah. So when they come back, that's when they now be saying, you know, in this place we normally, but they cannot do it. So that first period of even knowing your left from your right, this thing I've told you can take you a long time. And then somebody that you can ask, that can show you, no, this one, don't, this one. Take the wire, pull it back. When you are pulling out the wire, pull it like this, hold it like this, so that you don't spill blood. All those small things are the hard parts of the. But apart from that, once you get that vessel and you pass it, put on. Simple. The remaining is to manipulate and to know the do's and don'ts, and to recognize when you are in trouble or when you have caused trouble. Okay.
Can you just explain the introduction of the stent?
The stent. So after you have passed this wire, this is this catheter. This is the guide catheter, right? It's inside the coronary. You will have a coronary wire. There's no coronary wire here. Coronary wires are typically smaller than this. They're typically 0.014. Okay, there's some 0.018, but typically 0.014. There are different types. Polymer jacketed, non-polymer jacketed. Don't worry. So we'll now take that wire, very thin. We pass that wire through what we call a TUI. It's not here. We pass it through, and then we navigate that wire. We typically make a bend in that wire. We navigate that wire through the coronary vessels till we get to the place of the blockage and bypass the blockage. So let's assume that the blockage is here on this thing. We make sure the wire comes, passes the left main, turns to the left circumflex. All of that you are turning, enters it and crosses it properly and hooks there. So let's assume the wire is inside like this. Now the next thing is that you carry balloon. I saw balloon somewhere. Correct. Can you see the balloon? So this may have been a stent too, because the stent will have deployed inside the person, then the balloon will come out alone. So this is the balloon. You now take that balloon, take it to the back of the wire. This back of the wire is outside now. You take it, this one is inside the blood vessel. The back is smaller. You take it through that back, and then you pass it through. This is too big for this to pass, but that one is very tiny. You pass it through till you get to that point of blockage. So you have to be looking at it, what is the exact point, and then at that point now you now take these back parts, connect it to your inflation device, and then inflate. Now you might decide to prepare the lesion with a balloon first before putting a stent, depending on your analysis of the lesion you are looking at. If it's a very tight lesion, you want to put a balloon to prepare it first before you now put. Balloons typically will be non-compliant, and maybe we'll not talk about that. So we'll put that. Sometimes you might go straight with a stent, but if you go with a stent and it doesn't expand because the lesion is too calcified, you know you don't waste that stent, and you have put a stent inside there that is further complicating the matter. So all those things, but you also not want to use balloons unnecessarily, because balloon now maybe 400. So if you don't have to use a balloon, not necessarily use a balloon. But if you do not use the balloon to prepare the lesion, that's the standard. Prepare the lesion, especially if it's a tight lesion, then you follow up with the stent. And you can see that this is a very nice balloon.
This will be put inside the guide wire. Guide wire that's already
In the coronary vessel, coronary wire. The guide wire is the one you use to guide the catheter. While that one is the coronary wire. This is the balloon. For if it's a stent, the stent will have been on top.
Oh, okay.
Then once you inflate it, the stent inflates and stays there. Then the balloon comes back out. Okay. So you want us to inflate it now and see what happens. If there's me see. Sorry. Like bolombolo. I'm just doing this one, but in real life, you not use so you have to use the inflation device and measure the amount of pressure you are using and for how long you are. Because once you are inflating, remember that you are obstructing blood flow down, so you are theoretically creating ischemia. So you need to be careful about how long you inflate. Is it inflating at all?
It's coming up.
Okay, it's bigger now, Abi. This looks like a cotton balloon now. No, it's not. So there is some that are cotton balloons. We have some cotton balloons. They have small serrated edges. So if the lesion is very tight, we use for one guy, it did not work still. They have small microtomes. When you inflate it, it kind of cuts into the intima and the calcium there. You inflate, you reduce, you inflate, you involve so that it can cut, and then when you deploy your stent can expand fully. Okay, so that is that about balloon. Yes? Sorry, I don't have any stent that I can open. That will be somebody's house rent. No, we just use. But if we have institutional support, like device companies are helping, they will have old expired ones, whatever, that we can use that to demonstrate. We had hoped, and hopefully next year, by the grace of God, we get institutional support so they can give us simulators that all of us can practice. We'll be seeing it. It's not real radiation, it's not a real human being, it's just a box, but it has the feel as if you are passing it through, so we can all just have that feel and practice what we are doing. So unfortunately, they feel our market is too small, so we are sort of, but there's a lot of activity. We trust God that we'll get better with time. Yes, any other questions, queries, issues? What can go wrong? As soon as you deploy that balloon, you could tear that coronary. As soon as you deploy that stent, the whole world could go crashing. So as soon as you deploy the stent, you typically will be focusing on your intra-aortic pressure and your ST segment. You need to look at that. What else can go wrong? You could dissect the vessel. The vessel could dissect, and dissection could happen. There are grades of dissection. Whether it is small dissection, whether it is spiral dissection, whether it is a through and through, and all of that. So there are grades of that. So you could see that, and you could have all those problems. So coronary angiography, simple. Stenting, much harder. And then if you have a bifurcation stenting, much harder. Where you have to do two balloons at the same time and do a double kissing balloon. The balloons will be expanding at the same time, kiss, come down, and create. So all of that are all some technicalities. For every stent, they have their own category. So whenever we open the stent from the thing sterilely, we bring out the paper. The paper is inside too with it. So you bring the paper, you put on the patient, and you'll be looking at it, and you cross-check what you are doing. Okay, so those are the things. It's simple, Abi. Are they done in the cath lab?
No.
Hey, what happened? Maybe they put in at the sheet, the thing came out. CRT. They are done, Abi? They are done, Abi?
They are done, but
they have not moved out of the theater.
30 minutes ago.
Thank God. Okay, yes. Are there any other questions?
Next year or something.
You said?
Spoke about the
If you have support now, the simulator alone is about $1.5 million.
It's over $1 billion.
No, those are the kind of things that your government invests in. So we have a place where we are training, we are practicing, we are doing. It's not private sector cannot just go and invest in training and spend $1 million on a simulator. How much will you now pay to come and train? Even this 30,000 naira, people they say, what is happening? Why are you charging? Why didn't you do it for free? Do you understand? So some center, and it's not if you go to the US, it's not as if you see it everywhere. There are only few per region or something, one per region or something. So you might go to a training center, do small, go back. When they have a special one, they also have styrofoam structured like its coronaries, like this. So that when you are passing this wire like I'm doing, you'll be seeing how it is going, and you can be practicing navigating lesion, inflating balloons. And they have stents that are made for demonstration. They are just made scattered like that for you to use to practice. No, but it's still how everybody is trained, which is why you have to watch at least 100 cases. Then you start, by the time you watch 100 cases and you're reading, then you can, by the time you're doing the first case, to be easy. This thing I've showed you now. If I show you this thing 2-3 days, and then you are there assisting me, passing the wire for me, passing that 3-4, about after 10 times, you too will, I mean, you will get it now. You get, I am at a certain level of training. You are not a doctor yesterday. You have done femoral cannulation for dialysis, you have done all those ones. So you now come around and then you do that one. The remaining 2 you do. So in the US, I think you have to do 250 per year unassisted for you to now, in a year, for you to now qualify and then do the exam and then come out. So those are this. So, but if you are seeing it and then it's normally not, it's not a big thing. But as you are starting, that starting one is good. When they are trying to devise new technologies, those are the things they use. How will it behave inside the blood vessel? No, if you bend the catheter like this or like this. So all of those things are very important at that time. Okay. Are there any other questions? Queries? We've had a long day. And tomorrow is another day. If for those that are around, maybe we'll do the coronary together. For those that are not around, we'll gist you tomorrow. Right. We know they sleep. There's coffee. There's coffee. No, we'll sleep now. We'll sleep later. But I think we can do one coronary this evening or peripheral just to reduce the tally. Because we have 2 more CRT tomorrow again. That peripheral, have you looked at the CT? How far is bad? Please, if you have any questions, let us know. If they have left, if they are out of the cath lab, then we can take them in batches and discuss. Yes. Well done. Thank you, sir. Well done. So you spent time in India?
Yes.
And what happened now? You should have come back and started doing now.
Yeah, I was to spend 1 year there, but because of COVID,
Oh.
I was in Cardiocare along the way. So
Hey, but you should have come in here now. You have been coming here. We did during that COVID. We did plenty. We did plenty.
Yeah, I was actually repeatedly discussing with the doctor on coming.
Hey, you don't come now. Not you just come and take one of the house in Abuja and spend 6 months 1 year. Go back. See all I've learned without living here. I've not gone to India once. I've not seen any place once.
And you know that instead of sending people like what our institution did, it's better to have the facility, get an expert, and then doing it and build the capacity.
I've been here I've done like 18 months, and I've been.
Yes.
Initially, I wasted time. I thought it was not possible that it was. So I just. Then one day, I heard of somebody in Lagos doing that had never traveled. I said, hey, that means it's possible.